হ্যালো, 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 হ্যালো। আসছে? হ্যালো, 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 হ্যালো চেক হ্যালো, 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 হ্যালো চেক হ্যালো, হ্যালো চেক হ্যালো। গানটা চলছে। হ্যালো, হ্যালো চেক হ্যালো। 1, 2, 3, 4, 5, 6 হ্যালো, হ্যালো চেক হ্যালো, হ্যালো।
थोड़ा पीछे कर लो, ठीक है। अरे ना साइड पे
Good afternoon. The first scientific session will begin at 2 p.m. I think the first session speaker, Dr. Madhuchanda Kaur, has already loaded her speech. Dr. Madhuchanda Kaur's loaded. Next, Dr. Shormishta Mukhopadhyay. Third is Dr. Somdat Prasad, ophthalmology. Dr. Devanu Ghoshrai, cardiology. Dr. Dipanjan Pradhan. Alokda, can you contact Dr. Devanu Ghoshrai? Because he has to load his talk. The chairperson of the first session is Dr. Mihir Chaudhary. I think he is downstairs. And the chairperson of the second session is Professor Ashish Basu. Third session chairperson is Dr. Rotish Chandra Pal and Dr. G.S. Ramachandra. Medtronics people are here. Medtronics people is here. Have you loaded your thing? Medtronics. Dipanjan is downstairs. I have seen. If anybody can call him and tell to get his thing loaded. Dipanjan is downstairs. বলো হ্যাঁ হয়ে গেছে অডিটোরিয়ামে শুরু হয়ে গেছে আরে এরা তো তোমার আসেনি এখনো ওই কি বলে সোমদত্ত ওর তো জিনিসটা লোড করতে হবে ও তো থার্ড স্পিকার ওকে 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 ঠিক আছে ঠিক আছে ঠিক So if we are ready, Dr. Madhuchanda Kaur. Indradi, can you call Dr. Madhuchanda Kaur? Dipanjan is downstairs. We have several PCMDs as chairpersons. I would like to announce them in advance so that they can be present in the proper time. Dr. Hafizun Nisa, she will be the chairperson of the session 3 to 310. Is she here? Dr. Ashish Mukherjee, you will be the chairperson from the session 310 to 318. Dr. Meera Arora, I think she is downstairs. Dr. Aniruddha Kirtonia, you will be the chairperson from the session 350 to 4. Other CMDs will be tomorrow. But Dr. G.S. Ramachandran has not yet come. You have come, fine. So your session is from 225 to 235. Ophthalmology session. Dr. Somdat Prasad, if you can give your thing so that it can be loaded. Mondira, please help Dr. Somdat Prasad to get his pen drive loaded. Diyada, ওনার থেকে নিয়ে একটু লোড করে ডক্টর প্রসাদ ও ডাইরেক্টলি লাগাতে হবে তাহলে তো সেই সময় হ্যাঁ If somebody brings his own laptop, there should not be a problem. Audiovisual persons. Hello? Hello? যদি কেউ নিজের ল্যাপটপ আনে অসুবিধা নেই তো I will request all the speakers to be very precise and stick to their time, because as you have seen from the program, there are so many sessions. If we go on lengthening, then it will not end before our cultural program. So I think for the benefit of everybody, we should stick to our time. And I will request all the chairpersons to see that the speakers are maintaining their time. Mondira, Dr. Madhuchanda Kaur has come. Mondira, Dr. Madhuchanda Kaur. Dr. Mihir Chaudhary. Dr. Professor Ashish Basu has come. Shormishta, Professor Ashish Basu. Mandira, can you go downstairs and gently remind Dr. Madhuchanda Kaur that we are running late? Second speaker, the chairperson is having lunch. So can we start with Shormishta? Shormishta, can we start with you? Huh? But Somdat chairperson, yes, he is here. So we can start with Dr. Somdat Prasad because we don't want to waste any minute. So we'll start with the ophthalmology session. Dr. Somdat Prasad, the topic is clinical insights from the phase 3 study of faricimab in DME. The speaker is Dr. Somdat Prasad. And the chairpersons will be Dr. G.S. Ramachandra. Sir, will you please come and take your seat? একটু লাগিয়ে দিন ভাই।
আসছে? ঠিক আছে। Thank you very much. It's always a pleasure to be back here. লাগবে না রাখো। It's always a pleasure to be back here. I was told to speak about faricimab, but I think it's quite a very specialized topic. So I'll speak a little bit about diabetic retinopathy, how it affects our patients, what we can do about our patients. And then I will go into faricimab and why we are bringing it up. It is a newer line of treatment for amongst various treatments we have. Can you hear? Can you hear? ठीक है? Yeah. So I'll speak a bit about diabetic retinopathy as such, why we are so worried about it, what we can do about it, especially in your kind of setting where your patients in the railway are your employees. So they are like your extended family or captive population, if I may say that. So things I will try to tell here will not always be applicable to the outside world because obviously patients wander around. Why is it a problem? Well, diabetes is a growing epidemic, you know that. We see advanced diabetic complications all the time. People who, if they had been examined at the right time and treated, would not have got to that advanced stage when they were going blind. So the idea with diabetes, and if you can look at the map there, the red is in India and China. The maximum growth in diabetes is going to be us. So we are facing the onslaught of the epidemic. Diabetes growing everywhere, but more so in our part of the world. Now, about 5% of people with diabetes, so this is everybody with diabetes, out of them, 5% have diabetic macular edema, and about another 1.5% have proliferative retinopathy. So about 7% people of diabetes have vision-threatening diabetes retinopathy. And those are the people we as ophthalmologists are more concerned about. The other concern, obviously, is that if they have retinopathy, they are very likely to have renal disease. So it is important for the physician to know what to do from our end, whether they have any retinopathy or not. It gives you a clue of where else you need to look for or not. So I was talking about early detection. How can you do early detection? Let's just spend a couple of minutes on that. I'm aware we're going to keep to time. This was published in 2013. I was a co-author of this, and this is the paper on the basis of which the National Program for Diabetic Retinopathy Screening in the United Kingdom was set up. Why am I bringing it up? It is the only national screening system in the world which is successful. Every country in the world, in every advanced country in the world, the leading cause of blindness in the working age population is diabetic retinopathy. Not in the United Kingdom for the last 10 years. Why? Because of systematic screening. Why am I bringing it here? Because if some of you put your minds of it, you can do systematic screening for your railway employees and their families. That is doable because they are captive. Now, when this was done, 2000, about 10, this paper was written, this started a few years before that. Technology was different, but today we have small handheld fundus cameras, which are pretty inexpensive, under 10 lakhs budget actually. And the camera will take the image. You can train a technician to do it. It doesn't have to be me or some ophthalmologist doing it. The camera will take the image, and there's an artificial intelligence program which will grade it as normal or anything which requires attention. So 70-80% of your patients, the machine will say you're normal. You come back and have your photograph taken in a year. Now these cameras are quite small. Here is one picture. I have no financial interest. This is from a company called Remedio. These are quite small, about that big. You can just do it like that. Needs a little bit of training for the person doing it. And then it basically takes the picture on a smartphone, which is stuck to the back here. And that is linked to the internet. It generates a report from the software. You can give the report to the patient instantly, or it can go into your system saying this is that. So providing screening is no longer a major big hassle. It can easily be done. A little bit of organization is required. And that way you get, you do what is uh, very essential: annual retinal checks for diabetic retinopathy. Now, if you send everybody to a retina specialist, it's not going to be possible. There are too few retina specialists in Kolkata to see every diabetic every year. So this kind of system needs to come in, and places like the railways are actually the ideal, or the armed forces are the ideal places where you can bring these in, because you have your sort of defined population to deal with. Because what other people do outside is go and do these camps. These camps are brilliant. We have a camp for this, we have a camp for that. Basically, in the long term, they are meaningless. They help a few patients then, but what happens later on, nobody knows. So the camp approach works for acute things. I can do a cataract camp, I'll remove the cataract, put the lens in, patient will be happy, done, finished. For chronic disease, camps don't work. You have to have a systematic ongoing program. So coming on to what we do for treatment, we have had treatments for diabetic retinopathy for a long time, starting from the 80s when I went into medical college. There was no treatment, then came laser treatment, which basically halted progression or stopped it getting too bad. It didn't improve anything. Then around the middle of 2000, we got steroids, which we injected in the eye. It had its own problems, increased pressure, cataracts, but it did control things. Then around 2006, we got anti-VEGFs, which are the agents we're talking about today. Around 2012, they were licensed for diabetic maculopathy. So diabetic maculopathy actually became treatable. So it actually improved the patient's vision. But the problem is they required frequent injections. Every 4-6 weeks, they needed an injection. This was ongoing for the rest of the life almost. So it's logistically very difficult for both the patient and the doctor, and the system and the hospital. And diabetic patients are non-compliant. I don't blame them. It's not their fault. If why are they non-compliant? They have so many things to worry about. They have their diabetes, they have cardiovascular disease, they have neuropathy, retinopathy, everything. How many specialists are they going to go to? Are they going to work or spend all the time in hospital? So the more we can integrate the care into one center for them, into one place for them, the better it is, rather than saying আপনি চোখটা ওখানে দেখাবেন, কিডনিটা ওখানে দেখাবেন, ওই টেস্টটা ওখানে করাবেন. The more you can do it in one place, have a diabetes center, it is better for them. Keeps them in work, less time off work, which from an employer point of view is also beneficial. So we have effective treatments. I've told you what the problem is. I've told you how we can screen for them. I've told you what the treatment is. The problem with the treatment is the treatment burden is too much. The standard treatment program with anti-VEGF means that you give an injection. You first do an examination. Patient has diabetic maculopathy. You give them an injection. You give them one another month later, 3 or 4, depending on who you talk to, loading dose. And then you try to extend the gap. But this patient is going to be coming back to you every 6-8 weeks for the rest of their life. So it is obviously a huge burden. So the focus of treatment, after we got effective treatments in the middle, around 2012-14, the focus of treatment development on new drugs coming out has been to try to increase this gap. So instead of doing it every month, I should be able to do it every 3 months or 4 months or 6 months, however longer, the better. And to obviously increase effectiveness, because whatever we have is effective, but it is not a magic bullet. It doesn't, everybody with diabetic maculopathy will not improve on that. A lot of people will. The figures we give the patient is that 90% of patients will improve, and 90% of patients will remain stable, and 40 to 50% patients will improve, which does mean that where we start the treatment is very important. When we are starting the treatment from reasonably good vision and we can maintain it, that's great, which is where this early detection and early screening comes in. So this new drug faricimab, which we are talking about today, the advantage of this is that it works through 2 different mechanisms. In the past, we started with steroids, which we all know about. It's anti-inflammatory, inhibits various pathways concurrently, but also has some side effects which we don't like. And then we have anti-VEGFs, which attack the vascular endothelium growth factor pathway, which is the blue on your left. But this new drug now, that was ranibizumab, sold as Lucentis, Accentrix, etc., and various similar drugs, aflibercept, Eylea, etc. But this new drug also attacks the Ang2 pathway, so it works from 2 different pathways. So at least theoretically, it's just been introduced into India very recently. I've myself only given a few injections till now and do not have follow-up on it yet. But speaking to what the trial results are, and speaking to countries where it has been available before, it seems to be more effective and act for longer. Those are the 2 important things about this drug. As you know, the FDA requires these trials to be done. So there are 2 trials done on the basis of which this drug was licensed. It was first licensed for macular degeneration, then for diabetic maculopathy. I'm not going to go into details of the trial, but they were fairly large trials done over multiple centers in good settings. And the important thing really is that they devised a thing saying you can extend the interval. So you gave one, and then you gave the first three, and then you extended the interval, provided that the disease activity wasn't coming back. Now, what did that achieve? What it achieved is that a lot of patients could be maintained on 8 weekly, and a fair number could actually be 16 weekly, so 4 months. So from 1 month or 1.5 month injections, I've gone to 4-month injections. So that's 3 times a year. So that is a much less of a burden on both the doctor and the patient. So in that way, this is superior to what we have had till now, which is the reason to bring this up here. So at week 96, let's say 2 years. At 2 years, about 80% of patients manage to stay on 3 monthly dosing, which is 12 weeks. And a slightly smaller number, 60% of patients, were actually managing to stay on 4 monthly dosing. So we didn't have to take them and do it all, give them these injections as frequently as we have had in the past. Time will tell. We just started use in India very recently, so let's see what our experience is. But experience from the United States, Singapore, etc., where it has been available, is telling us this, and obviously from these trials. So the key points really are DME management. The key is anti-VEGF injections. Now these newer agents, faricimab, which attacks both anti-VEGF and the Ang2 pathway. There's some role for laser still, and that is for non-center involving macular edema. There is some role for surgery in patients who have obvious vitreomacular traction, something pulling on the retina is mechanical, has got to be removed, or in very advanced problems, which I'm not bringing up today. So basically, we've talked about how to detect things early so that they can be treated early, how to do it at a cost-effective manner using AI to sort of not bog down everybody else in that, how to improve compliance without putting extra pressure on the patient. He has to go to 10 patient places, go another place, and use longer acting and maximally effective treatment agents, so they have to come in less often to us. Thank you. You want me to take questions now, or? Oops.
Thank you, Dr. Somdat Prasad. Any questions from the audience? Okay, sir. Dr. Satya Babu.
Yes. Absolutely. That is the whole idea. You train a technician to do it, so you don't need a doctor sitting there doing it. So that the diabetic physician is seeing his patients as they come out, those who have not had it for a year, have this picture taken and generated. And also, most importantly, what it will do is it will keep a record and generate a recall in a year. We're just occasionally screening. I have friends, cousins, family members who are doctors, diabetic. They come to me and say, "Oh, I haven't had my eyes seen for 5 years." They all know they should have it done once a year, but they don't. So if we take it to where the patient is going to be, at his physician, then it will get done. And the system will generate a recall. They will send an SMS message saying your eye checkup is due. Please go and have your picture taken, which is not a very time-consuming job.
How frequently it should be done, sir?
Once a year for people who have no retinopathy or background retinopathy. If they're more than that, then obviously you have to tailor it more often.
Thank you.
Okay. Thank you, Dr. Prasad, for the meaningful talk and very lucid presentation. And thank you, Dr. Satya Babu. Only one question I have for us, sir. Cost effectiveness of this, and would you like to advocate this in the divisional hospitals?
This is running in Kerala and primary healthcare centers, the instrument I was showing you. So divisional, yes, obviously. Cost effectiveness, like I said, the whole equipment costs about 7-10 lakhs, not more than that. So it's not a huge amount of money. And if you think about how much money it is going to save, especially in a setting like yours, if you keep somebody who is visually disabled, they cannot drive the train. if I can keep them seeing, they stay in their job. So overall, it might not be cost effective for the hospital, but for the railways, it will definitely be cost effective.
Does it require any special training for the ophthalmologist?
No, the ophthalmologist can do it, but I'm talking of getting technicians to do it. So they will require a little bit of training.
Okay, thank you, sir.
Thank you. I will request our chairperson, please, sir, 1 minute. I'll request our chairperson, Dr. G.S. Ramachandra, to give a token of appreciation, a memento to our speaker, Dr. Somdat Prasad. And I also request Dr. Mondira Banerjee to give a memento to our chairperson, Dr. G.S. Ramachandra. So we move on to Dr. Shormishta, Dr. Madhuchanda Kaur. Fine. We'll move on to our next speaker, Dr. Madhuchanda Kaur. And the chairperson will be Dr. Mihir Kumar Chaudhary. He's not here. May I request Dr. Paul, hello? Dr. Mihir Kumar Chaudhary is not here. So may I request Dr. Aniruddha Kirtania to please come and chair this session. Dr. Madhuchanda Kaur will be talking on osimertinib, real-world evidence as first-line therapy in NSCLC. I don't know the full form of this abbreviation. Maybe.
আছে হাতে ধরবো হ্যাঁ থাক আপনি বলুন স্টার্ট করব
Dr. Madhuchanda Kaur needs no introduction. One of the very well-known medical oncologists on this part of the country. So back to Dr. Madhuchanda Kaur to start.
Good afternoon, Chairperson, and all my friends and members of the Doctors Club in B.R. Singh Hospital. It's really a pleasure to talk in front of you, but unfortunately, it will be a very specific oncological discussion. So I'll try to make it in such a way that all others also understand, not going into the very details or minute details of the presentation. So basically, the landscape of oncology has changed, like rheumatology and other subspheres of medicine. We have learned the biology of the disease. And learning the biology of the disease, we have also understood that there are certain driver mutation. That means oncogenic drivers. If we can identify these oncogenic drivers, then we are on target. And with this targeted therapy, we can really make a lot of change in the life and outcome of the patients. So today's discussion over the next 5-10 minutes will be on what has really been the change in lung cancer in those patients who have a particular type of mutation in their cancer, and this is known as EGFR mutation. We specifically talk about two genetic deletions, EGFR 19 and 21. So this is in a nutshell what we want to highlight. And since there are drugs available to target these deletions, the outcome of these patients has really changed over the years. And it's a pleasure seeing patients enter your clinic years and years, months and months with lung cancer, which is metastatic, and still have such a reasonable quality of life. They do their daily activities, they do go back to their occupation, to their profession, and even with nervous system metastasis, they have such good outcomes. So that in a nutshell is what I'm going to talk about. So this is the typical registration trial. You needn't know the details. It was the FLORA trial on osimertinib, which is the best first-line therapy available now for EGFR mutation. And in the trial settings, all these were great outcomes, be it progression-free survival, be it the overall survival. So you can see that with the use of osimertinib, the curves started separating from the very beginning. And this separation continued for months. You can see, even after 2 years, the separation was well maintained and sustained. So that was the beauty, and that is the beauty of targeted therapy in oncology, not only in lung cancer, but in the different spheres. Same for overall survival. Unlike PFS, overall survival curves ultimately come together. And here also, after 51 months, the curves started coming together. So you can see what was a life for only 3 to 6 months has changed over the years to a very prolonged and sustained overall survival. The beauty of today's presentation is highlighting on the CNS outcome. Those with metastasis in the CNS, look at their outcome. Here also there is early separation of curves. So we only knew of cranial radiotherapy for brain metastasis. Here we have an option in EGFR mutation that these drugs also have CNS protective effect, and CNS response is also observed. Are they without side effects? No, there are certain side effects. Mostly, in my practice, in my experience, osimertinib is one of the best tolerated drugs. Up till now, I have not seen even a single patient stop osimertinib because of any adverse events that is intolerable. Of course, grade 1, 2 adverse events are there, but not to the tune of stopping the drug. So the conclusion from the study was that osimertinib causes a significant improvement in the progression-free survival, overall survival, and the safety profile shows that it is a very, very well-tolerated drug. So the questions. What I discussed was a trial scenario. Everything ideal, no diabetes, no hypertension, ideal age, fitness. But in real world, do we really get this type of patients? So is the FLORA data replicable in the real world setting? That is the moot question. So in the real world setting, we have to assess whether what I write in VR Singh Railway Hospital Clinic, I can replicate the FLORA trial data. So how do we address this question? We have many real world studies, of which very famous is the flower study, because it's a prospective study. There are European studies, Japanese studies, Spanish studies, all these are there. Even in very elderly, there is a study. Elderly, you can see, beyond 75 years who are not considered in the clinical trials at all. And in this real world setting also, it is really exciting to find that the progression-free survival not only was matching the ideal situation of FLORA trial, but even better in certain studies. I showed you so many names of the studies, but I should also declare that not all the studies were ideal, randomized, prospective. Many were retrospective, observational. So study trial design is not replicated, but yes, real world setting is evaluated. So the beauty of these studies showed that what was ideal in the flora is being replicated. See, the median progression-free survival was nearly 19 months. And all these studies, some of them even showed better results. So yes, in our practice also, we are very much confident with osimartinib, except the financial toxicity. This drug is really a well-tolerated drug. Efficacy is unquestionable. And in real world, we have been able to replicate what was seen in the initial registration trial. Even the safety data was very, very much acceptable. No difference in survival outcome was observed according to the age, comorbidities. We did include all comorbidities in the real world studies because you see, we recruited diabetics, hypertension. So yes, real world data and the FLORA trial, which is ideal, that data has been replicated in the many studies that we have seen with osimartinib in the clinic practice. And before I end, we always question and we always say, এত বয়স হয়ে গেছে একে আবার এত দামি দামি ওষুধ দেব? So look at the excellent results seen in patients beyond 75 years. They've done so well. এর মাথায় ছড়িয়ে গেছে, ব্রেনে চলে গেছে, একে নিয়ে আর ভাবনা চিন্তা করব? Yes, again, such good results with CNS metastasis. So here is a drug which, if used in first line in non-small cell lung cancer, in the particular patient who has got EGFR deletion 1921, if we choose it properly, if we work up the patient properly at the very beginning, then we can replicate these results even in elderly and even with CNS metastasis. So the NCCN, which we all follow, guidelines, has put osimartinib as a first-line treatment in that particular group of patients who really benefit from such drugs. Thank you for the very patient hearing. I hope I've been able to convey the message that don't be pessimistic, don't be nihilistic, have positivity in this particular group of patients who will really benefit if you use the correct drug in the correct patient. Thank you all.
Thank you. Dr. Kaur, please, we have a small token of appreciation from our chairperson.
So no questions? Nahi, all are confused. So no questions.
No, not confused. We are convinced that this is a very nice drug.
Okay.
So no questions.
Then it's okay.
And we are running out of time, not short of time, out of time. So we will discuss during the dinner. Any questions? If there is any questions. Okay, I'll request our chairperson, Dr. Aniruddha Ketonia, to give a memento to our speaker, Dr. Madhuchanda Kaur. And I will request Dr. Mondira Banerjee to give a memento to our chairperson, Dr. Aniruddha Ketonia. So we move on to our next session, that is an endocrinology session. The speaker is none other than Dr. Shormishta Mukhopadhyay, and chairperson is Professor Ashish Basu. May I kindly ask them to take their stage? Just a small announcement. All the speakers of the next coming speakers, if they have not yet loaded their pen drives, may kindly come to the audiovisual person and get it loaded.
It's a great pleasure and privilege for me to be here, for being invited to share my experience. Really, I am carried away by a sensation of nostalgia because I had worked in B.C. Hospital for more than 4.5 years in 1980 to 84 and beyond. So it is a sort of homecoming event for me. And the session today is very close to my heart, the diabetes. And we'll be discussing, rather, Shormishta will take us to the journey of insulin beyond 100 years. And the theme of the heart talk is that, is it patient friendly as of now? And Dr. Shormishta is very erudite speaker. Currently, she holds the chair of Secretary Diabetic Association of India West Bengal chapter. So I think within this stipulated time, Shormishta will be in a hurry to do justice to the subject assigned to her. Over to Shormishta.
Thank you, Chairperson, sir. Respected seniors and my dear friends, I will be talking for the next few minutes on a very interesting subject, insulin beyond 100 years. Is it more patient-friendly now? Now, these four pioneer scientists, Banting-based MacLeod and Collip, discovered insulin in the year 1921, and when they successfully injected insulin to a type 1 child, Leonard Thompson, and for that, in 1923, exactly 100 years back, they were awarded with Nobel Prize. Now, for the next 100 years, insulin has saved millions of lives, but still, people are afraid and apprehensive of taking insulin because of certain drawbacks. The most important of these is hypoglycemia, followed by painful prick, weight gain, hypersensitivity and allergic reactions, lipohypertrophy due to anabolic action of insulin, and lipoatrophy due to antigenicity of insulin. So, what we are discussing today is that over the 100 years, the newer technologies, the newer insulins, newer devices, how they have changed the insulin molecule and made them more patient friendly. So what are the limitations of conventional insulins, the age-old insulins which we use, like NPH insulin and soluble regular insulins? The most important thing is that they are not truly physiological. Insulin, when we administer from outside, is given in the systemic circulation, whereas our physiological insulin is secreted in the portal circulation. So there is a mismatch definitely. Ideally, the basal insulins should not have peak. They should be peakless so that there is no hypoglycemia. But our basal insulin, conventional one like NPH, has a peak, and that may cause nocturnal hypoglycemia. Whereas the meal-related insulin, they have delayed onset and peak, just not like our physiology. So there is a mismatch between the glucose surge and the insulin surge. And that causes poor postprandial blood glucose control, late postprandial hypoglycemias, and poor flexibility. So with the advent of newer insulins like Lispro, Aspart, and Glulicin, all of you know because these are available in our hospital. So there are minor changes in the amino acid sequence which keeps them in monomeric form. So it makes this simple things makes them more physiological, and so they can be used more in case, their onset of action has become 10 to 15 minutes instead of 30 minutes in case of conventional insulin. So there is good postprandial control. The patients with unpredictable eating pattern, they can be given this even after the meal. Children with afternoon snacks, because of shorter duration of action, this can be administered to them with good success, and it can be used in hypoglycemia prone individuals. Nowadays, we are moving from rapid acting insulins to ultra rapid acting insulins, which are also available in our hospital. Here we have faster aspart, which are formulated with some niacinamide for faster absorption and L-arginine to improve stability, and that onset of action has become 2.5 minutes only. Whereas ultra rapid acting Lispro, which will come to the market very soon, they have treprostinil, which causes absorption via local vasodilatation. So the onset of action here is only 1 minute. So such a physiological product is this, and this causes non-inferior HbA1c reduction but better postprandial control. Now, regarding the basal insulins, true peakless insulin has evolved over time. In 1946, we had NPH only. In late 90s, we had Glargine 100 and Detemir, and in 2010 and 2011, we have Degludec and Glargine 300. And you can see here that as the time passes, the basal insulin has become more and more peakless. It was like that initially, and gradually it becomes having less peak, and finally it has become completely peakless. So regarding the mechanism of action of this generation 2 basal insulin, it forms a compact subcutaneous tissue for the Glargine, which causes less resolution, and for Degludec, it forms a soluble multihexamer by making deposit in the subcutaneous tissue, and this shows that these two generation 2 insulins has got less nocturnal hypoglycemia and any all-day hypoglycemia, and also robust HbA1c control. Now, regarding the co-formulation, previously we had premixed insulin like NPH with soluble, NPL with Lispro, and NPA with aspart. But nowadays, two separate components of insulin, one is Degludec and another is aspart, we have in the co-formulation this Degas 7030. So previously there were certain limitations like shorter action of basal analogs due to intermediate acting basal analog use, and shoulder effect because of interchanging of the components. But here two distinct identical insulins are there for basal and for this rapid acting, and so we have more physiological insulin. Once weekly insulin icodec will come very soon with certain amino acid substitution and addition of C20 fatty diacid. We have slower receptor activation and gradual slow release from the albumin with better glycemic control and also less mitogenicity, which is a concern for Glargine. So once weekly icodec not only will have better HbA1c reduction as it has been evidenced, but it will also improve the compliance. Now we have certain biosimilar insulins too. Biosimilars are the officially approved versions of original innovator products and can be manufactured when the original product's patent expires. So we have they are actually large and complex structures and manufactured from the living sources, unlike generic ones. And so we have biosimilar Glargine in our country, and the most important advantage is that they are much cheaper. So we can use the efficient insulin in a cheaper the cheaper version of it, and within few days or few weeks we will have Glargine and lixisenatide combination, which is a combination of basal insulin along with GLP-1 receptor agonist. So we have these two insulin and GLP-1 receptor agonist at the same time, very much useful in obese subjects, and will control probably both fasting and postprandial glucose. And later we will also have Degludec and liraglutide, which are being seen in the horizon. Single smart insulin also is being tested in experimental stage in animal model. An addition of gluconic acid forms a polymer-like complex where insulin is trapped and slowly released with alteration of signal, so that different amount of insulin is released in response to different blood glucose levels. So basically it is a bionic sensor is there, and it will be very useful. Inhaled insulin Exubera is launched in 2006, and nowadays it was withdrawn, but nowadays we have Afrezza, which has only 25% bioavailability, but it has not become so popular because of its certain concerns. Although it is painless and hypoglycemia is there, but there is dry cough, asthma, COPD, etc. So we are not presently not using it much. And we have now continuous glucose monitoring system. That is also a novel approach apart from glucometer. So when patient can afford it, it has been seen that mean A1C in patients who are using this CGMS is much less than than who are not using. And it can measure the glycemic variability, detects the nocturnal and anytime hypoglycemia. So it has made insulin therapy much easier and more predictable. And finally, the insulin pump. We have the basal regular rapid acting or faster acting insulin analog used in it, which actually supplies the mini boluses. There is continuous infusion, which constitutes 40 to 50% of the basal insulin, and the meal related insulin can be adjusted empirically. So it is a semi-automated machine. It has two varieties: traditional insulin pump and patch pump. And also in the horizon we are seeing that automated system of insulin like bionic pancreas is coming, where insulin delivery is totally dependent on glycemia due to the sensor, inbuilt sensor. And probably in future we will also have bihormonal completely automated system where glucagon and insulin both will be available, and that will act as true artificial pancreas. There are certain problems related to insulin pumps like mechanical pump failure, like superficial infection, and also dose reduction when the patient is nil per mouth. But still, definitely, apart from the cost, it is a milestone in insulin therapy. So take home message is that over last 100 years, insulin molecule and devices has become more patient friendly. Analog insulins are more patient friendly as they are more physiological, causing less hypoglycemia and better PP control. Co-formulation insulin is more effective. Once weekly insulin icodec will increase efficacy and compliance. Biosimilar insulins have decreased the cost of therapy. Newer co-formulation with glargine and lixisenatide are in pipeline. Human insulins are less antigenic, so there is less lipoatrophy. Thinner needles are almost painless. And finally, insulin pump and bionic pancreas have revolutionized the therapy. And CGMS will help a lot in insulin therapy in coming days. So there are at least 5 Nobel Prizes which are available from insulin, awarded for insulin, but no single anti-diabetic agent apart from insulin have got Nobel Prize. So that only glorifies the insulin as a magnificent molecule. It has a glorious past, it has a magnificent present, and probably it has a marvelous future too for next 100 years. Thank you very much for patient hearing. If there is any question.
Dr. Shormishta, for a very nice but brief overview and almost time bound. So that's the beauty of our lecture, as I have been hearing for years together. So she has more or less covered the insulin journey right from when the bovine insulin leading to mad cow disease, then the uh, not purified insulin leading to antibody formation, then the monocomponent insulin, and then down the line the ultra fast and the combination insulin, that is the co-formulation, and the lixisenatide and glargine, and again the glargine 300 GLA. That's a also beauty insulin. So the dose, the it requires the requirement of the volume is less, and that is also patient friendly. But at the end of the day, the pocket friendliness is also better.
Yes.
It should be considered. So that is an important point.
Definitely.
So due to the paucity of time, question cannot be entertained. So those who are interested can interact with Dr. Shormishta. Thank you.
Thank you.
And now I request Professor Ashish Basu to give a token of appreciation to Dr. Shormishta Mukhopadhyay, a memento from IRHSA BR Singh Hospital. And I'll request Dr. Amrita Naha. Chobi uthe gache? Yes, I saw flashes. Yes, our official. Thank you, Debashish. So I'll request Dr. Amrita Naha to give a memento to our chairperson, Professor Ashish Basu. We will move to our next session, cardiology session. Our speaker is Dr. Debanu Ghoshrai. I'll request our speaker to come to the dais, and chairperson is none other than Dr. Alok Mujumdar and Dr. Lakshmi Gujiwal. Dr. Lakshmi Gujiwal. Gujial. Sorry.
Good afternoon, seniors and colleagues. I have the privilege of chairing a talk on a very recently described clinical condition, WHF or worsening heart failure. And this worsening heart failure is a stage in the course of the heart failure patient who is under proper GDMT, that is guidelines directed medical therapy. Despite that, the patient develops symptoms of heart failure, signs of heart failure, needing escalation of his diuretic dosage, either orally, intravenously, or even hospitalization. So I think this WHF, what is the importance of this WHF and what next? This would be talked about by Dr. Debanu Ghoshrai, very senior interventional cardiologist, a year junior to me in college. And we have had the good fortune of working for about 2-3 years together in Peerless Hospital. So over to you, Debanu.
Good afternoon, chairpersons, seniors, colleagues, and friends. So today we will be discussing about worsening heart failure. A lot of things have changed over the past decade, including the definition of heart failure and the way we treat heart failure patients. With availability of excellent medical treatment now, heart failure is easy to treat with better survival and better quality of life. So what is heart failure? It's a structural or functional cardiac abnormality. It has to be corroborated with an elevated NT-proBNP. That is very important. And with objective evidence of either systemic congestion or pulmonary congestion. So all the three should ideally be present in a patient of heart failure. Now, basically, when a patient has risk factors, and the very beginning of the chart, you can see they are prone to develop heart failure, like a patient with hypertension, diabetes, or coronary artery disease. Then they have baseline heart failure when we initiate treatment, and then they improve. But then they start having episodes of heart failure and hospitalization. And this is the stage where we call it worsening heart failure, where the treatment is slightly different from that of an ordinary heart failure. And finally, the patient goes into advanced heart failure, where we go for devices and heart transplantation. Now, every heart failure patient today, it is absolutely essential that they receive the 4 first-line therapy for heart failure. And those include an ARNI, a mineralocorticoid receptor antagonist like spironolactone or eplerenone, a beta blocker, and an SGLT2 inhibitor. So every patient, if not contraindicated, should receive all the 4 first-line heart failure therapies in appropriate doses, maximally tolerated doses. Why? Because they will reduce mortality, they will improve the quality of life, and they will reduce hospitalization. There are problems of using these drugs, like there could be worsening of renal function, there could be hyperkalemia, and there could be hypotension. But then every drug has some problems, and you have to take care of these problems, and you have to treat accordingly. But remember, these problems are more severe in patients who are old and who are frail. the benefit of using this drug is that you can actually reduce the event rate. Event rate means hospitalization or death from 19.9% to 14.3% in 1 year. So you can imagine how serious heart failure is a condition where 20% of the patients are dying within 1 year and 50% of the patients are dying in the next 5 years. And if you can reduce it by about 25%, with the use of 4 drugs, that is excellent. But then still you see plenty of patients continue to have heart failure hospitalizations, and it is important that we actually reduce these hospitalizations. Worsening heart failure actually occurs in 1 in 6 patients, and 80% of the heart failure patients will have one or more worsening, and unfortunately almost 20% of them will die in the next 1 year. Now in heart failure, we have the excessive activity of the RAS system, of the sympathetic nervous system, and also the neprilysin system. So we are using beta blockers, ARNI, SGLT2 inhibitors, and mineralocorticoid receptor antagonists. So these are the 4 first-line therapies. But in spite of using these 4 first-line therapies, if the patient continues to have hospitalization because of heart failure, then the wonder drug now is vericiguat. Vericiguat is a stimulator. It stimulates this soluble guanyl complex and increases the cyclic GMP, that increases the myocardial contractility and reduces heart failure. And this was tested in the Victoria trial, where patients in class 2 to 4 were included with an ejection fraction of 45%, and 2/3 of them had an hospitalization in the last 3 months, and almost 90% of them had an hospitalization in the last 6 months. Or they went to an emergency and received an IV Lasix for worsening heart failure. And you can see that more than 5,000 patients were included, significant heart failure with an elevated NT-proBNP, majority of them in functional class 3 or 4, and many of them had chronic kidney disease with eGFR up to 15. And you can see these patients were very well treated with all 4 first-line heart failure therapies. Now you can see that there was an absolute risk reduction of 4.2 events per 100 patient years. And that is, if it is 1 or 2, we are very happy. 4.2 is very, very good for any cardiac drug. And you need to treat only 24 patients for 1 year to prevent 1 death or heart failure hospitalization. So that is the extent of benefit that you can get with vericiguat. It is very easy to use. It is very well tolerated drug. You start with 2.5 milligram once a day. Any time of the day you can take it, and after 2 weeks you go up to 5 milligram once a day, and if tolerated, go up to 10 milligram once a day. So it is, and the price is same, 2.5, 5 or 10. So go up to 10 milligram per day. But remember, this is a PDE5 inhibitor, so do not use sildenafil with this drug. As I said earlier, very safe drug to use, very tolerable, hardly any adverse effects. And in this chart, you can clearly see that the adverse effects of the drug and placebo were same, and there was no hypotension, there was no syncope, and more than 90% of the patients could achieve the full 10 milligram dose. Even in patients who are high-risk patients, like patients who had hypotension, patients who had chronic kidney disease, and patients who had hyperkalemia, this drug could be safely used in most patients. So to summarize, quadruple therapy, I think, is the most important today. Every heart failure patient, you must give quadruple therapy in maximum tolerated doses. That includes the ARNI, the beta blockers, the mineralocorticoid receptor antagonists, and SGLT2 inhibitors. If you have done this, if you have given these 4 drugs, you have done most of the good work that a heart failure patient should receive. But yes, if the patient continues to develop worsening heart failure, with some patients who will develop, do not hesitate to start vericiguat, because it is a very effective, very safe, and very well tolerated drug. and the benefit is actually very, very good. It's like any other drug, any other first line drug, and maybe soon we will see very soon got also being included in the first line drug. With that, you need to do other therapies like IV iron and lifestyle modification, or maybe lanoxine or vaccinations. All these things are also important in heart failure treatment. So thank you very much for your attention. Any questions I can take up? Yes. SGLT2 inhibitors are basically heart failure drugs. Yes, they also reduce blood sugar. The extent of benefit with SGLT2 inhibitors in heart failure is exactly equal in both diabetics and non-diabetics. So SGLT2 inhibitors we consider to be a drug to be used for cardiac protection as well as for kidney protection. The additional benefit we may get is that it can also control diabetes.
Then, if there are no questions, we could end the session by thanking Debanu for his wonderful talk. And just as a chairman's prerogative, I would like to add one thing, which he has highly emphasized. Use the 4 drugs. That is the most important thing in a heart failure. May not be in the, because the strong heart failure trial had showed that use even the smallest dose. But since the 4 drugs act in 4 different pathways, the benefit would be obtained, and gradually try to up-titrate within 2 to 3 weeks. No. Thank you so much.
I will request our chairperson, Dr. Alok Mujumdar, to give a token of appreciation, a memento, on our behalf to our speaker, Dr. Debanu Ghosh-Rai. So many cardiologists, you can find out the cameras are out. So I now request Dr. Amrita Naha to present our chairpersons with mementos on our behalf. Madam, please. We'll move to the surgery session. Amient hernia and a perforated appendix with enterocutaneous fistula. The speaker is Dr. Dipanjan Pradhan, and the chairpersons I would like to invite to the stage Dr. Anandodas Chaudhary and Dr. Hafizul Nisa. Please take the stage. I will request the speakers to stick to their time. We're running late by 15 minutes.
Next কোনটা? Next কোনটা? এইটা?
Good afternoon. Hello, Kolkata. It is so pleasure to be here. And thanks to Dr. Chaudhary as well as the Eastern Railway for inviting us to be here. And the topic today for this is a perforated appendix with enterocutaneous fistula. It's a really a complicated one to kind of treat actually. Here, this Dipanjan Pradhan is there. I hope you'll illuminate this thing.
Thank you. Thank you, everybody. Welcome to B.R. Singh Hospital from Department of Surgery. Today, I am going to present in front of you a very rare case, in fact, a case report, which we have recently published in an international journal. So, what is Amyand's hernia? Amyand's hernia refers to the presence of vermiform appendix within the inguinal canal. It is a very rare entity. Only 1% of the hernia cases, you will get this type of cases. But appendicitis, that means inflammation of the appendix, in this setting is rarer, only 0.1%, 2.08%. And perforated appendix in an ambience hernia is rarer still. So it is a very rare thing. We are fortunate that we have received this patient 300 years back in London. Claudius Ammiant first performed appendicectomy located in the right inguinal hernia in an 11 years old boy. This patient also had a intracutaneous fistula. But why this happened, what are the risk factor, we still don't know because of this rarity of the disease. Now, as I have told you, we have published this case in companion journal of International Journal of Surgery. This patient was 64 years old, gentleman. So we are always delighted and excited to see our B.R. Singh's name in some international journal. So the appendix within the hernial sac may become isolated from the rest of the gastrointestinal tract, which can cause further confusion in the clinical diagnosis because the abdomen will be soft. It is not be like normal appendicitis. So being aware of this possibility sometimes help in clinical diagnosis. So these are the presenting features. 64 years old gentleman presented with a complaints of painful swelling over the right inguinal region for 15 days, associated with a malodorous discharge from the swelling 2 days back, and the pain progressively increased in severity. There was no fever, abdominal distension, or dysuria. Patients had comorbidity of diabetes and hypertension. So you can see from this picture that the whole of the lower abdomen has become swelled, inflamed, red, and there was a necrotic ulcer in the middle of the inguinal area. So patients were clinically conscious, oriented, hydrated, afebrile, hemodynamically stable. CVS and respiratory system was normal. On abdominal examination, we found a soft abdomen with normal bowel sounds, but there was a tender erythematous swelling in the lower part with an ulcer. Parectal and examination and testis was normal. So in investigation, we found the total leukocyte count to be raised. Renal function was normal. USG, urgent USG showed some sort of strangulated inguinal hernia. So our provisional diagnosis before emergency OT was some sort of intracutaneous fistula in a setting of strangulated hernia. However, the final diagnosis was confirmed intraoperatively. So we start off with giving broad spectrum antibiotic and other supportive care. He underwent an emergency right inguinal exploration under general anesthesia. The subcutaneous phase was necrotic. Along with that, there was pus and necrotic tissue. This was debrided, and the right spermatic cord and the thickened indirect hernial sac with a perforation was identified and dissected. The hernial sac contained a perforated inflamed appendix with 5 into 3 millimeter fecalith inside it. So this is the intraoperative picture where you can see the base of the appendix was normal. So there was no ileocecal pathology. We did appendicectomy, standard appendicectomy. There was 3 into 2 centimeter right direct inguinal hernia along with this indirect sac. So we did herniorrhaphy. We don't try to put mace because of this infective setting. Subcutaneous corrugated drain was placed and followed by primary wound closure. So this is the picture. You can see just a few centimeters from the tip, there was a perforation, and otherwise the appendix base was not inflamed. So in this picture in the left, you can see the appendix. In the middle, you can see the fecalith. And in the right side, there is the hernial sac. So the post-operative period is uneventful. The corrugated drain was removed on the 5th post-operative day. Subsequently, the histopathology reports come to be a necrotizing appendicitis. And on 2 and 6 week follow-up, the patient was doing fine. So these ambience hernia usually much more common in children than in adult, and usually due to a patent processus vaginalis, it is much more common in children. Usually these are seen in the right sided. Usually they present as a strangulation. intraluminal obstruction in the form of fecalith, and extraluminal obstruction due to narrow deep ring usually are the predisposing factor for appendicitis in this subset of patients. Now, as I am emphasized earlier, the clinical presentation was confounding because the gastrointestinal system seemed unaffected from the pathology based on the history and clinical examination. This was most likely due to isolation of the appendix within the hernial sac from the rest of the gastrointestinal tract. So the isolation of the appendix almost functions like auto-amputated appendix. So inflammation and adhesions could trap the appendix within the hernial sac, leading to strangulation and perforation. So our final diagnosis was made intraoperatively. We found a fecalith within the lumen. Probably that may be the cause of the appendicitis and perforation. And the perforation could result in translocation of the bacteria into the subcutaneous spleen, depending on the integrity of the hernial sac. In our case, the perforation of the appendix and the hernial sac caused such bacterial translocation, causing tissue necrosis and eventually leading to formation of intracutaneous fistula. So to conclude, Ammian's hernia is a rare entity. The clinical presentation is variable and preoperative diagnosis is difficult. Isolation of the appendix from the rest of the GI tract could add to the confusion in the clinical diagnosis. Ultrasonography and CT scan are valuable tools for preoperative diagnosis. Management of Ammian's hernia should be tailored according to the pathology encountered, and treatment should not be delayed. So there are a few references. So I will end my top say with a beautiful quote that the beautiful things about life is that we will never reach an age where there is nothing left to learn, see, or be. It's magical, really. Thank you so much for hearing.
Perforation was due to strangulation, or whether perforation was due to strangulation or due to old age and diabetes and fecalith.
Thank you, Dr. Sunil Kumar.
Base of the appendix was normal.
Yes, yes.
So
Thank you, Dr.
not
Sunil
due
Kumar.
to strangulation, but due to fecalith and diabetes mellitus.
Yes, sir, I have mentioned in that slide this last thing. The most of the cases, the whole appendix become inflamed, and because of the raised intraluminal pressure, appendix usually, and at the same time the wall of the appendix also become inflamed, and it loses its potential strength, so it becomes perforated because of the increased pressure in the intraappendiceal lumen. But in these cases, probably the appendix was pathologically normal, but due to the obstruction somewhere in the neck of the hernia, there was a strangulation. Along with that, there was a fecalith. Probably that has caused the necrosis of the wall. So it may be a local cause that has put this thing.
In old age, due to atherosclerosis of the appendix.
Yes, yes, yes.
And fecalith is there, and diabetes patient was diabetes.
Yes, comorbidity with diabetes and hypertension. Yes, sir.
Thank you, Dipanjan, for very excellent presentations. And this is a very rare, I have not seen. And incidentally, Ammian is first surgeon who performed any type of appendectomy in that case. Okay, thank you.
Yes. Yes, this was, we have not written in the slides. We had CT's facilities, but at that time, CT machine was out of order. So we didn't perform. I'm so sorry. But because this patient came in the evening and we had to operate at the middle of the evening, so we didn't lose time to do the CT for the next day. So we did a USG, urgent USG. And as the patient was debilitated, so we thought it will be better to operate the patient in the evening. So we didn't wait for the CT for the next day. But definitely CT will be helpful. Definitely. Your point is taken, well taken, sir.
Thank you. That was a very nice discussion also. So I'll request now to our chairpersons to hand over a token of appreciation to our speaker, Dr. Dipanjan Pradhan. I will request Dr. Mondira Banerjee to present our chairpersons with our mementos. Before I move to the next session, I may take the advantage of welcoming our DGIHS, Dr. Shugandha Raha, to come. She has come all the way from Delhi. We are pleased to have you here. So we move, in the morning we saw live sessions of surgeries. So it will be nice to have some knowledge about the instruments that we often use in the lab surgeries. We have a small session, lab surgery equipment details. This will be the next session. It will be done there. You need not the mic. Okay, it will be presented from background. Nobody will be speaking.
The textile anatomical mesh fits in easily with your surgical workflow. First, orient yourself to the mesh by ensuring the ML marking is readable and placed towards the medial plane of the patient's body. Dissect to obtain a critical view of the myopectoneal orifice. Ensure you can visualize critical landmarks prior to mesh insertion. Press the medial edge of the mesh and gently introduce it through the trocar using a 10mm trocar for medium and large mesh sizes and an 11mm trocar for the extra large mesh size. Allow the mesh to unfold. The unique structural design enables the mesh to maintain its shape after trocar passage. Confirm positioning by ensuring the medial edge overlaps the patient's midline. Gently direct the inferior flap laterally to align with the anatomy, and guide the unsealed inferior edge down to the retropubic space. Finish the procedure per the tap or tip technique used. Make sure that during space deflation, the lateral and inferior edges stay flat against the abdominal wall and do not roll up as the inguinal space desiflates. Surgeons everywhere are discovering the difference. Enhanced design, full inguinal anatomy coverage, textile anatomical mesh.
Whether you prefer polyester or polypropylene mesh, our hernia care portfolio offers the material choice you require for your patients. ProGrip self-gripping polypropylene mesh for open inguinal hernia repair is now available as part of our comprehensive hernia care portfolio. Featuring a proprietary microgrip technology, ProGrip self-gripping meshes have been a top choice for surgeons around the world. Resorbable polylactic acid microgrips facilitate tension-free adhesion to the surrounding tissue, eliminating the need for traditional fixation. These microgrips support tissue integration for at least 8 weeks as they are progressively resorbed. Over time, as they resorb, the mesh weight is reduced. The material is comfortable to handle, can be trimmed according to patient anatomy, and by eliminating the need for traditional fixation, placement is simplified, resulting in reduced procedure times. In fact, operations without suture fixation are shown to be an average of 8 minutes shorter, with positioning and placement of mesh completed in just 1 minute. And the benefits for your patients are clear. Pain experienced as a result of traditional fixation can be avoided by reducing trauma to the tissue, as well as the risk of nerve entrapment and injury. This has been shown to result in lower dosing of post-operative narcotics. And recurrence rates for patients receiving ProGrip self-gripping mesh are extremely low, similar to or lower than suture fixation. With 47 clinical studies published in journals you trust and demonstrated success in 27 countries, ProGrip self-gripping mesh has been proven safe and effective, earning the trust of surgeons like you worldwide. And now, with the availability of polypropylene in addition to polyester, you can select the material of your choice to meet the needs of your patients.
So to continue with the scientific session, the second part will be starting with a nephrology session. The topic, chronic kidney disease, taming a raging bull. The speaker, Dr. Puranjoy Chakraborty, and the session will be chaired jointly by Dr. Ashish Mukherjee, CMD, East Coast Railway, and Dr. Rana Bhattacharya, Senior Consultant in Nephrology, B.R. Singh Hospital. I request our chairpersons, Dr. Ashish Mukherjee and Dr. Rana Bhattacharya, to kindly come onto stage, and the speaker, Dr. Puranjoy Chakraborty.
Thank you. So, good afternoon to all of you. It will be a interesting session, definitely. And to speak on the matter, we have got a very able speaker, Dr. Puranjoy Chakraborty, who is young in years, but has got years of experience. He is a DM in nephrology, and he has got several publications to his credit. And at present, he is my colleague in B.R. Singh Hospital Department of Nephrology. And without wasting much time, I would request Dr. Chakraborty to please start the session. Kindly keep in mind that you have got 8 minutes in all to finish your talk. After that, the session will be open to discussions, so you can ask your questions after the topic. Thank you.
Yes, thank you, sir, for the kind introduction. Firstly, I would like to say thank you to this august audience who have gathered here today. And I'll also like to thank Indian Railways Medical Service Association for giving me this opportunity in this prestigious platform to present today, and also to Bayer to for sponsoring this session. Now, my topic today is chronic kidney disease, taming a raging bull. This name has been appropriately given by Sir Dr. Rana Bhattacharya to exemplify exactly the relentless and the ravaging nature of the disease, which I will present in the next few minutes. So first, we have to understand that what is the definition of chronic kidney disease. This is the definition given by KDIGO guidelines, and it states that there should be a marker of kidney damage in the form of albuminuria, urinary sediment abnormalities, electrolyte or other abnormalities, abnormalities detected by any histology, detected by any imaging, or history of kidney transplantation with or without decreased GFR less than 60. If you go below, you can see that is the GFR categorization which have been introduced, which forms the pillar of the CGA classification. This slide is also important because this presents the grading of the albuminuria, which is also used to define CKD, along with the GFR, and this is popularly known as the heat map. You can see there's a specific coloring from green to yellow to orange to red, and as it progresses, as it becomes red, things become even worse. So what is the burden of the disease? It is a progressive condition which is affecting 13.4% of the world population, more than 800 million people. This is 2017 data, and it is continuously increasing. ESKD accounts, which is the last stage of chronic kidney disease, it accounts for around 4.9 to 7 million population. Specifically, it's a large burden to the low and middle income group countries like ours. Elderly women, racial minorities, hypertensives, and diabetics are specifically vulnerable. It is recognized as a leading cause of mortality worldwide. The global all-age mortality attributed is around 41.5%. 5.2 million years of life lost and 1.7 million years of life lived with disability. That is the morbidity amount. This is the second part of the disease, the financial impact. You can see this is a comparison table. We are comparing it with two other big bosses when it comes to mortality, morbidity. You can see myocardial infarction and heart failure. And if you compare the last stages of CKD, when the patient is requiring hemodialysis or peritoneal dialysis or transplant, look how exponentially the cost increases. It is almost 4 to 5 times of treating a myocardial infarction patient. So this is how it eats away the economy. As we say, CKD doesn't only kill the patient, it also kills the family, it kills the institution, also the country economically. So a brief etiology, diabetes is the most common cause worldwide. Hypertension, glomerulonephritis, PCKD, pyelonephritis, congenital anomalies of the kidney and urinary tract, tubulointerstitial disease, obstructive nephropathy, a few genetic disorders, and more drugs in contrast. Drugs that are used in cancer chemotherapeutics, other drugs, and a lot of contrast agents which are now being used for various studies. These are the new devils, the new things that have come up in the last 10 to 12 years. Cardiorenal syndrome. As we have more amount of elderly population living with cardiac failure, either reduced or preserved ejection fraction, as has been previously mentioned in the previous sessions, we have more and more drugs like ARNI to keep them going. But one of the side effects is the cardiorenal syndrome they produce and increases the amount of AKI and CKD. Contrast-associated nephropathy. There is some degree of renal dysfunction, AKI is associated with the use of ARNI and SGLT2I, as has been mentioned by the previous speaker. CKD-U or CKD of unknown origin, and also obesity, which is also a global pandemic. This is a brief idea of the glomerular filtration rate. This is how we categorize the EGFR. Till 60, everything is okay. Less than 60, things become bad. And as it reaches 15, it is known as end-stage kidney disease. Why we use this nomenclature? Because the kidneys are no longer compatible with life and you need special things to support the kidney function. When we treat the kidney disease, we do not only treat the kidney, we treat a lot. That's why the finances or the expenses increases, because we have to treat all this. Hematopoiesis is affected, you have to treat the anemia. Mineral bone disorder, you have to treat vascular calcification or high turnover diseases. Acid-base imbalance in the form of metabolic acidosis and concomitant dyselectrolytemias. Water retention, heart failure, volume overload. Blood pressure control. Nephrologists do not use less than 3 to 4 antihypertensives. Normal blood pressure can be controlled by 1 or 2 drugs. CKD population, you will need minimum 3 or 4 drugs. Cardiovascular health, cognitive dysfunction in the form of stroke, in the form of dementia, and other uremic features. This is a small case. You can say I have presented this to place the situation. Mrs. AG, a 66-year-old lady, wife of a retired employee, visits the nephrology OPD concerned and apprehensive. She gives a history. She has been suffering from diabetes for the last 15 years and was on therapy. Her blood glucose was usually less than 200, so pretty decent control. She never had a renal function test before 2021, but eventually got tested because of her feet swelling, and the creatine was 1.69. After that, medications, she took some which reduced the swelling, and she did not do any further testing. From the last 2 months, again, she developed decreased appetite and feet swelling reappeared. When she again tested, it was 4.12. So what went wrong? She was on therapy. She had a pretty good control of diabetes. So this is the raging, the relentless and the unforgiving nature of the disease. Diabetes, as I mentioned, is the principal etiology. You can see untreated diabetes has a decline of EGFR at the rate of 10 to 12 milliliter per minute per year. How to tackle? We have to control diabetes, blood pressure. I will go into these things in the next slides. The best we can achieve is to reduce the 10 to 12 to 2 ml per minute per year. So what armamentarium we have? Diet and lifestyle. This is the first pillar. Salt restriction, avoidance of food rich in potassium and phosphate, water management, protein at 0.8 gram per kg per day, calorie restriction, and regular exercise. Along with this, we need blood pressure control, diabetes control, avoidance of nephrotoxic drugs, avoidance of analgesics, avoidance of infections, either through drugs or vaccinations, and treatment of concomitant disease like heart failure, CLD, rheumatological disease. We have new agents now. RAS inhibitors were the old people who were fighting around. Now we have SGLT2Is, we have ARNIs, and we have GLP-1 analogs. Now I will talk about something that has been added to this list. It's called non-steroidal MRA or finerenone, popularly known as Carandia. It is a newest addition to the armamentarium. The data we have got from Fidelity trial, which is a combination of Figaro and Fidelio trials, it has immense cardiovascular and renal benefits and antiproteinuric benefits, as well as anti-inflammatory role. What is it targeting? It is targeting the MR overactivation loop of the diabetic kidney disease. The trials have mainly been conducted in the diabetic kidney disease, and it is fighting the inflammation and the fibrosis. These are the two trials that were done simultaneously, the Figaro DKD and the Fidelio DKD. Fidelio DKD looked at the kidneys, Figaro DKD looked at the heart, and Fidelity was the total combination of the entire data. And from the kidney and nephrological point of view, there is a definite benefit. You can see it reduces the risk of ESKD or the stage 5 progression by 20% versus placebo. So this is the new thing, the new recommendation from august bodies all over the world. They are saying the non-steroidal mRNA should be there in the treatment of patients with kidney disease. Lastly, I would like to mention the new novel horizon that has opened up, something called the gut-renal axis. Manipulation of the gut flora has been used in other diseases also, like Parkinson's disease, even heart disease, CLDs. So it is also being done in the kidney disease portion. And it has been seen that the gut microbiota interacts with the kidney through diet, microbiota-derived uremic toxins, and immune-mediated factors and various metabolites. So manipulation of that by drugs can also retard the progression of chronic kidney disease. This is some evidences, but it's an ongoing novel thing. The exact dose, the exact duration is still not sure, but newer drugs we require, because obviously by this time you have realized how bad the problem of chronic kidney disease is. The fight till the last, yes, when everything is lost, still because of advancement of medical technology, we can keep the patient alive, which was not possible 20-25 years back. We have dialysis modalities for ESKDs in the form of hemodialysis, peritoneal dialysis. We have renal transplantation, and that is also having a lot of good outcomes in the last 10-15 years. And we are looking forward to what is artificial kidney. It is under formation for last 10-15 years, but still positive results haven't come out. Thank you.
So the session is open for questioning from the audience, please, if anyone is interested or anyone is eager. So I really don't find anyone wanting to ask any questions. So thank you, Dr. Puranja. It was a wonderful presentation. Sir, would you like to ask some questions to him?
No, I would just say that this was a excellent presentation, and practically in the railway scenario, kidney disease is a big problem, but there's something like in the PPP mode, we are starting that hemodialysis units in many of the divisional hospitals, so we are managing a lot of cases that way, but it's a big burden. And this drug, I think finerenone or something what you said, is something that when you started, it was a very depressing kind of thing, that everything was negative, but this word actually gave some feeling of well-being, that is one drug is there that will help the patients immensely. And I think
Thank you, sir.
Actually, the entire point is that we would not allow the disease to progress beyond a point when it becomes a financial burden or when it becomes a health burden, health challenge. So in this respect, the number one thing that is very, 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 very important is proper counseling. Proper counseling means the patient has to be educated about the disease process, the prognosis, the treatment available. If the patient and the family members understand the disease, then the acceptance becomes very high. And once the acceptance is there, they would comply with whatever we are saying. And the OPD and the outpatient nephrology outdoors, the services over there is very important, because we can catch these patients at a very early stage. For me, I am ashamed. I am extremely ashamed to say that I have got 1,450 patients on hemodialysis. I am ashamed. I am ashamed to say that I've got 25 patients on peritoneal dialysis. I am ashamed to say that I've got 80 patients on transplantation. That reflects that the disease had progressed to a point when these people needed this. So when I get a patient of create, say, 1.4, 1.5, 1.2, I would love to have a go at them and counsel them so that they follow and they're regularly followed up and their disease doesn't progress. And finerenone is definitely one of the drugs, because beyond a certain point, beyond stage 3, we cannot use finerenone. So whatever the medicines are there, so they have to be used in the early stages. After this, all these developments are go out for a toss. So thank you, Puranja. It was very nice, and you finished the talk well in time. And thank you, the audience also. You listened to it very aptly, and thank you very much. Thank you, sir.
Thank you.
So after trying to tame this raging bull, I will request Dr. Ashish Mukherjee to present a memento to the speaker, Dr. Puranjoy Chakraborty. And at the same time, we will be presenting mementos to our chairpersons, Dr. Ashish Mukherjee and Dr. Rana Bhattacharya. So we quickly move on to our next session, a gynecology session, and that includes an oration, Dr. Ira Ghosh Memorial Oration. The topic, Stress Urinary Incontinence, Surgical Management Revisited. And the speaker for the oration will be Dr. Amit Basu, a former Chief of Obstetrics and Gynecology, B.R. Singh Hospital. And the chairpersons will be Dr. Meera Arora, Principal CMD, Central Railway, and Dr. Amitabh Mukherjee, again a senior consultant in gynae and obstetrics of the city, and who has had a long association with this hospital as a HVS for over 20 years. I request our chairpersons to kindly come onto stage, and our speaker, Dr. Amit Basu.
A very good afternoon to all of you. The subject has already been mentioned, and since it's a memorial oration, I have to garland Dr. Amit Basu with a medal. Before that, you can see whatever is written about Amit Basu. On a personal level, I know Amit for over 30 years. He's an avid academician, and he had special interest in urogynecology as well as laparoscopic surgery. And on the top of that, he's an excellent surgeon and a clinician. So let me garland him first with the Ira Ghosh Memorial Medal.
We are fortunate to have Mrs. Ira Ghosh's daughter with us today. Dr. Rupa Mitra is here with us in the audience. I would take the liberty to invite her on stage when Dr. Amit Basu is being, garlanded with the medal. Dr. Rupa Mitra. She has been the medical director of Garden Reach Railway Hospital, and she has come today to attend the oration as well. Abdul.
Okay.
I.
Respected chairpersons, my seniors, colleagues, and dear friends, this is indeed a very, very special moment for me. I must thank the organizers who have given me this opportunity to deliver Dr. Ira Ghosh oration.
and that too in the annual conference of the institute where I have worked for more than 30 years. So thank you very much. And today I'm going to talk on the topic of stress urinary incontinence, the surgical management, past, present, and the future. I must pay respect to Sir Early Holland, who in the year 1922 coined the term stress urinary incontinence. This is an important and very interesting slide. It is a statistics that came out, and it showed that 84% of female CrossFit athletes, they had reported urinary incontinence. And also, on the contrary, there was only 48% who complained of urinary incontinence in participants who were not for CrossFit exercises. So the leakage was most common with jumping, weightlifting, etc. So this is what happens. There's an increased intra-abdominal pressure due to sneezing, coughing, or weightlifting, and the internal and the external urethra opens. So this picture came into fame in one of the leading sports magazine in 2012 in Seattle Olympics, where Olga Slutinska won the gold medal for Lesbania in women's squat of 50 kg and dribble. You can see there is evidence of stress urinary incontinence. So the chief complaint is interesting because most of the patients are reluctant to complain of SUI. They accept it with age and parity. Some may divulge, that too when asked for. Only a few would come up to you with specific complaint, and that too those who have a distressing or distressing leak. So this is a patient which I saw in BR Singh OPD. And she was complaining of stress urinary incontinence. So when we asked her to sneeze, this is what happens. So you can see that this is quite distressing. And now, what are the surgeries we do for stress urinary incontinence? The goal of surgery is to provide sufficient urethral resistance to prevent urine leak from the urethra during increased intra-abdominal pressure, while preserving the voluntary low pressure complete bladder emptying. So to elevate the bladder neck and proximal urethra into the intra-abdominal position and align it to the posterior superior aspect of the symphysis pubis. So this is our goal. Now, if you go through the surgical journey of SUI, it is long back in 1864, Baker and Brownie first presented some interventions. Goebel invented this pubovesical slingplasty in 1910. 1940, Aldrich with autologous bladder neck, and this is written in green because this again came back. Marshall Marchetti Krantz, 1949. In 1961, Birch Colpo suspension, which still exists. And then came the golden era of polypropylene mesh in 1998. However, 10 years later, there was a sort of ban and suspension by RCOG. So again, this Colpo suspension and Aldrich sling came back. So these are the common surgical operations which we do nowadays, but we can't describe all of them today. This is the Birch, which is most commonly done. We do a transverse incision in the abdomen, go retroperitoneally, identify the symphysis pubis, the back of the symphysis pubis, the back of the superior pubic ramus, the urethra, and the vesicle, and the bladder. So this is the paracolpos. A surgeon puts in a finger inside the vagina to lift this paravaginal space, and you take two sutures over here and fix it to the Cooper's ligament. This I'll show you in a video. So this is how the assistant puts in the finger in the vagina to lift up that space where you take the stitches. This is, you don't have to go through this. 2 stitches are taken at the mid-urethral level and 2 stitches are taken at the uretrovesical junction. So the success rate of Birch is 85 to 90%. 5-year survival success is 70%. And there is no significant difference between open and laparoscopic Birch. Now, if we consider laparoscopic Birch-Colpo suspension, we have to identify the superior edge of the bladder. By retrograde filling of the bladder, you can use normal saline with methylene blue. And you give a peritoneal incision from one umbilical ligament to the other. So this is, you have identified the superior end of the bladder, and from one umbilical ligament, you go through to the other umbilical ligament and dissect retroperitoneally until you reach the inferior surface, the posterior surface of the symphysis pubis and the superior pubic ramus. So yes, gradually this white portion you can see the symphysis pubis posterior portion and the superior pubic ramus. And this is the urethra, I mean the urinary bladder and the urethra. So the uretrovesical junction is also evident. This is the obturator foramen, and this is the paracolpos where you have to take the stitches. So if I slightly fast forward, so this is the finger of the assistant who pushes the vagina up, and this is the paravaginal space, where paraurethral space, where you take stitches, 2 on each side, and these stitches are fixed into the Cooper's ligament of the ipsilateral side. So this is how this operation is done, and the stitches must not be very tight, but it should be like an hammock, just lifting the uretrovesical junction. So one side is complete. Now you can do the same on the other side. And so 2 stitches need to be placed on either side. One, as I said, at the uretrovesical junction, and one at the mid-urethral level. So that is it. And it is fixed to the ipsilateral Cooper's ligament on each side. So this forms a hammock and lifts the uretrovesical junction up into the intra-abdominal position. So that finishes the operation. And what you need to do after cutting, check the hemostasis, and just the peritoneum which you have cut, you can just suture the peritoneum so that the operation is completed. So this is how you close the peritoneum and finish the operation. So that was laparoscopic Birch. And then in 1998 came the era of polypropylene tape. This was a magic operation because it was equally successful as the Colpo suspension of Birch. Success rate 80 to 85. It treats 30% of women, even with overactive bladder, gets their symptoms relieved. And the operation can be completed in less than 30 minutes. So in Colpo suspension, we find that there is a prolonged stay in the hospital, 7 days at least, and a long recovery period. Whereas in contrast with these mesh procedures, it can be done in 30 minutes. And so it was a cost-effective alternative to patients and surgeons. This is the same patient which I showed earlier. Now we are doing this transvaginal tape obturator in B.R. Singh Hospital only. We in fact held workshops in our hospital to teach other health units and other hospital doctors in our B.R. Singh Hospital. So you hold the urethrosil, the vaginal mucosa, with 2 alleys, and then give a precise incision on the mucosa. This has to be very precise, otherwise you might cut the urethra. Now arbitrarily you think this is the symphysis pubis and this is the inferior pubic ramus. So your aim is to dig a tunnel between the urethra and underneath the inferior pubic ramus so that you reach the obturator foramen. So with my fingers, I'm doing a blind dissection and a blunt dissection. I'm going underneath the inferior pubic ramus into the obturator foramen. So this has to be done on the other side as well. And this is the urethra which has been skeletonized. So you have 2 tunnels on either side through which you can reach the obturator foramen. So what you next do is you locate the adductor tubercle where adductor longus is inserted, draw a straight line in the inguinal region and a horizontal line from the clitoris on each side. The intersection point denotes the point which is the safe entry zone into the obturator foramen. So that is how you identify. And since you have dug the tunnel, this is the needle which goes in, but you see your left index finger is in the tunnel, and it will prevent the needle to pierce the urethra or the bladder. So your index finger guides the needle out, and when it comes out, you just have to fix in the tape in the eye of the needle, and then just rotate the handle of the needle so that the tape comes out from the intended area on the groin. So this is how one side is done, and the same, just by derotating, you take out the tape on the left side of the patient, and then you just catch hold of this and go to the other side. So this one side is done. Now after doing this side, you go to the other side, and the other index finger now provides the guard, and with the left hand needle you enter into that space and you can feel the needle and take out the needle and tape it. So this way you can prevent injury into the urethra and the bladder. So both sides tapes have been taken out, and now you have to be careful that the tape over here has no twists or turn, and it has to be straight. So when you pull on both the tapes, it will snugly fit on the urethra, but there is a but always, there can be over tightening. So before pulling, what we do is we insert a Mayo scissor in between the urethra and the tape and pull on the Mayo scissors so that there is no much of extra tightening. So here we put in the Mayo scissors and then pull the tape on either side so that the tape snugly fits on the Mayo scissors and there is no over tightening. So that completes the operation, and after pulling, there is no more readjustment of the tape. All you need to do is just cut the tape and suture the vaginal mucosa which you have initially cut. So that marks the end of the operation, and the patient can go home the next day after removing the catheter, and she has her symptoms free from the next day only. So there was a 5-year follow-up comparing birch colpo suspension and tape. There were 770 patients, and the gist of the study was there was longer mean operation time and longer significant length of hospital stay in the birch group as compared to the TOT group. And even there were fewer unintended functional outcomes in birch. So much so was what we were going in the present, but there was a time to rethink. After 10 years of introduction of the tape, there was an article by Jonathan Gornall, a journalist, who documented the rapid rise and precipitous fall of the tape, a story that offers lessons for the entire medical community and for manufacturers and regulators. It was published in BMJ in 2018, how mesh became a 4-letter word mess. It left thousands of women irreversibly damaged, thousands of compensation claims. So the RCOG circulated a high vigilance restriction on the use of mesh, and its use was suspended in NHS. Daily Mail Australia, 30th November 2017, banned mesh. 12th September 2018, the Scottish government instructed all health boards to completely stop all transvaginal mesh procedures. Australia banned it. Again, there was a sigh of relief. There was an update about the regulatory actions, and Australia approved urogynecological mesh devices like Johnson & Johnson, Gyne-TVT device, tension-free Gyne-TVT obturator system, etc. So there was a big sigh of relief. The US FDA administration has not banned transvaginal mesh, despite its issue of warning about the use of transvaginal mesh products in pelvic organ prolapse. But the FDA ban only applies to transvaginal mesh for pelvic organ prolapse, but you can safely use the mesh for repairing stress urinary incontinence. So that is the present picture, and the future, of course, is robotic surgery. With that, you can give more precise treatment to your patients. And well, thank you very much. Wish you all a very happy new year 2024. This is the year of the dragon, and the Chinese horoscope predicts the year of dragon will bring luck, wealth, power, and strong leadership skills, which I believe all of you have. Thank you again for giving me this opportunity.
It was a pleasure listening to you, Dr. Basu. We have heard so much about you, but this is the first time I'm actually listening to you giving a presentation. It was a masterly presentation, and the point that I would want you to clarify that it has been banned about 10 years back. Does it still remain banned, or is there a relaxation?
Madam, the pelvic organ prolapse, the apogee and perigee mesh, they are banned. We cannot use them for pelvic organ prolapse. But for stress urinary incontinence, we can use polypropylene mesh. This is where we stand today.
So there has been some element of relaxation.
Yes.
And because you have such a vast wealth of experience, what has been your experience with these meshes while you were in practice in BRC?
Ma'am, we have done at least 700 cases of all of us, the urology department and the gynecology department. We have done at least 700 cases. And one or two cases came back to us with prolapse of the mesh, erosion of the mesh. And that was successfully treated. But the others, they were very happy. They came for follow-up and none of us had, in fact, they were very happy.
So a big hand to Dr. Basu on this count, because like all of us who have been handling these cases off and on, it is a nightmare when the patient presents to you and you honestly don't know where to send these cases. So going forward, because DG Madam is with us, and I think you are still associated with BR Singh in many capacities. We would be looking at some kind of hands-on training seminars for the rest of the gynecologists.
Unfortunately, man, I've left 2 years back. I'm in a private setup now. But then I will be more than happy to come and
Some
to
kind
be
of
in
hands-on
any time
training
for
workshops.
hands-on. Anytime, ma'am.
Any question from the audience? Because it's a really very vexed kind of issue that he is tackling.
Okay. Thank you, Amit. So we close this session.
And before closing the session, I will request our chairperson, Dr. Meera Arora, for presenting a memento to Dr. Amit Basu. Sir, Dr. Amitabh Mukherjee may please join in the presentation. And we again take the privilege of presenting mementos to our chairpersons, Dr. Meera Arora and Dr. Amitabh Mukherjee. So after an extensive session and oration on gynecology, we move on to our next session, that is the rheumatology session. And that is the Runa Mukherjee Memorial Oration. The topic, Management of Psoriatic Arthritis. The speaker, Dr. Paromita Bhattacharya, and the chairpersons, PCMD Eastern Railway, Dr. Mihir Chaudhuri, will be gracious enough to chair the session, along with Dr. Sharbani Sengupta, a senior consultant in medicine and rheumatology of this hospital. I will request our chairpersons to kindly come onto the stage.
It's a really great and emotional moment for us, and especially for me, as Dr. Runa Mukherjee was our very dear Runa Di was practically my mentor when I joined Indian Railways in B.R. Singh Hospital, Department of Medicine. And it's really a proud privilege for me to pass on my legacy from my mentor to one of my student who has passed her DNB post-graduation from B.R. Singh Hospital, and will now deliver the oration in the name of Dr. Runa Mukherjee. So she is Dr. Paramita Bhattacharya. She is no more a student because she's an assistant professor of internal medicine in JNM Medical College now. So I would another thing I would like to invite Dr. Amitabh Mukherjee, who is a brother of Dr. Runa Mukherjee, and has sponsored this medallion in the name of her elder sister and our dear Runadi. And with my co-chair, our very dear PCMD. I think we all three can come together to present the medallion to our ex-student, Dr. Paramita Bhattacharya, who will be the orator today.
Thank you, madam. Very good afternoon to all of my senior teachers present here, and my seniors, my colleagues, and my dear juniors. It is also a very proud moment for me as a ex-student of B.R. Singh Hospital to be present here and give this talk in this oration. Today, my talk of today's topic was on management of psoriatic arthritis, but due to time constraint, I have restricted this, try to restrict this in recent advances in the management of psoriatic arthritis. So the learning objectives of my talk is to incorporate classification criteria into assessment of suspected cases, apply an integrated approach to therapeutic intervention, incorporating patient-centric evidence and best practice recommendations for each treatment domain of psoriatic arthritis, to describe the mechanisms and latest safety efficacy evidence for approved and emerging biologic and non-biologic DMR therapy for the treatment of psoriatic arthritis. Now, starting with a case scenario, Mr. X, 36-year Hindu male teacher, presented with multiple joint pain for 2 months with skin eruptions for 2 years. The patient statement, patient had skin eruption which has multiple reddish scaly lesions with different shapes, mainly on extension surfaces of both extremities, scalp, sacrum and natal clefts. Scales are dry, thick, white and some places large sheet-like. No oozing, no discharge, but notice bleeding on scratching over the lesion and appearance of new lesion on the scratch area. That is, Auschwitz sign was positive as well as Koebner's phenomenon. On joint examination, especially knee and ankle joints were found to be swollen erythematous with restriction of muscle active movements and muscle wasting, along with tender joint margin, and patellar tap sign was also positive. Nail signs were there, that is pitting, horizontal ridging, hyperkeratosis, onycholysis. So how this patient can be classified as a case of psoriatic arthritis? For this is the criteria for classification of psoriatic arthritis called Casper classification criteria. To diagnose, we must meet the patient must have inflammatory articular disease with more than equal to 3 points from the following category, including personal history or family history of psoriasis, nail dystrophy, negative rheumatoid factor test, dactylitis, as well as radiographic evidence of juxta articular bone formation. For which diagnostic workup is needed, from medical history to examination and blood test and imaging. For clinical presentation, there are varied type of presentation, starting from asymmetric oligoarthritis to this DIP involvement, dactylitis, enthesitis, psoriatic skin lesions, and nail changes. These are the several manifestations, among which 50% cases are asymmetric oligoarthritis. Others are depicted in the pictures. Here, there is shown as swollen joint, and there is asymmetric oligoarthritis, there is mutilating arthritis, and also as well as dactylitis and sacroiliitis. This is how dactylitis present. Enthesitis. Now, how do the disease activity is measured? There are several methods like minimal disease activity index, CPDI, etc. Among which MDA, that is minimal disease activity index, is very important, for which 5 out of the 7 is needed. That is tender joint count less than 1, swollen joint count less than 1, tender enthesial joint count less than 1, along with other parameters like global activity, patient VAS activity, and others. What are the available therapies? Starting from NSAIDs like naproxen, indomethacin, etoricoxib to conventional and systemic synthetic DMRG, that is disease modifying anti-rheumatoid drugs like methotrexate, leflunomide, sulfasalazine, all are recommended and available for long time. Now, the recent drugs is available and recommended for our biologic therapy. Biologics and medicines genetically engineered. These are other, there are some mechanism I have shown, like this is a nomenclature how this is monoclonal to chimeric to monoclonal humanized antibodies are used in the treatment of psoriatic arthritis. These are the various mechanisms. These are the other drugs like fusion inhibitors, abatacept and etanercept. These are the newer targets like from skin, enthesis, gut, microbial, bone marrow, joints, as well as the enthesis. From our targets, newer targets are interleukin 23, 22, interleukin 17, interleukin 17, as well as TNF alpha, like previously present, and as well as interleukin 22, for which the newer drugs are anti-TNF biologics. These all are recommended. Adalimumab, etanercept, golimumab, infliximab are all recommended. These are the several mechanisms of action, how they act. The newer agents, anti-interleukin 17 agents, acts here. Mainly 2 drugs are currently available and recommended, that is secukinumab and ixekizumab. This acts prevents the inhibition of structural damage as well as causes greater skin clearance of plaque psoriasis. These are other drugs, that is ustekinumab, anti-interleukin 12-23 agent. Study has shown to less radiologic progression in this group of patients treated with these agents. There are other drugs like guselkumab. I have shown in this diagram here. Ustekinumab. These are also used like interleukin 12-23 inhibitor, interleukin 23 P19 inhibitors. These are the dose and mode of administration. I will not go into details due to time constraint. But how will monitor these cases? Biological monitoring must be done with CBC, liver enzyme tests, renal profile assay, and CRP every 3 monthly. These are the other drugs like abatacept. I have already told, co-stimulation inhibitors. They significantly increase ACR20 response, but it should not be used with other TNF antagonists nor with other biologic therapy. The newer drugs, that is, but all these drugs I have told or discussed, all were injectables, either subcut or intravenous injectable therapies. The newer drug is used and given orally. These are JAK inhibitor. These are mainly tofacitinib and baricitinib, which has approved, and also recently upadacitinib is also approved. Other drugs, filgotinib or ruxolitinib, are under phase 2 or phase 3 trial. This drug acts via inhibition of JAK-STAT pathway and inhibition of cytokine production, thereby decreasing inflammation. These are the newer targets. They are the tofacitinib inhibits JAK3 plus JAK1. Baricitinib acts against JAK1 and JAK2, whereas upadacitinib acts against JAK1. Filgotinib is a selective JAK1 inhibitor. This is under phase 3 trial. But before administering all these biologic agents, we must do a TB tuberculosis screening and do management for those cases found to be positive. The other drug which is already approved is phosphodiesterase 4 emitter, which inhibits reduces inflammation by inhibiting NF-kappa beta pathway associated inflammatory pathways, and they are shown to be improved in enthesitis and dactylitis in various studies. So what are biosimilars? The biosimilars are several drugs like biologics, but something is different. But these are cheaper than biologic. Those patients cannot afford biologic, we can give them biosimilars. There are several differences of biosimilars and biologic, starting from size to molecular weight, structure, etc. So treatment of psoriatic arthritis should be an integrated approach involving dermatologists, psychologists, as well as rheumatologists. So various drugs which are effective in various domains like enthesitis and axial arthritis like angst like presentations, we can use TNF inhibitor as well as interleukin 17 inhibitors in these sort of cases. The therapies which are currently in development are guselkumab and vimelkizumab, which are interleukin 17 and A and 17F inhibitor. Now, the recent importance is given to treat to target therapy, that is TOT. There is a study called TICOPA study, which highlights the possibility of adapting treat to target approach in psoriatic arthritis cases. There are two recommendations important. These are GRAPPA recommendation, that is Group for Research and Assessment of Psoriatic Arthritis. They also stress achieving for focused on achieving low disease activity for disease domains of psoriatic arthritis. These are the various domains how we'll treat according to GRAPPA recommendation. The skin, there are treat to target for skin patients also. And there are several URL recommendations, but they are also aimed at reaching the target of remission, either low disease activity or minimal disease activity. And they have given some phase-wise therapy, how to approach these cases from starting from phase 1, phase 2, phase 3 to phase 4. Phase 1, if not improve patient, then we will go for phase 2 and wait for 3 to 6 months, then go for another phases. And including various therapies I have already discussed, there is option for class switching. But how will define the case has achieved remission? There are several remission criteria like DAPSA and PASDAS remission criteria are also there. So after all this brief discussion, the take-home message should be like that: early diagnosis and initiation of therapy is very important modality, and treat to target therapy it should be achieved. And it is shown that 80% patients had presented with skin lesions and appear at the same time or precede. So dermatologists have the opportunity to identify patients who should be referred to rheumatologists for very early diagnosis. Preliminary screening tools also exist, but the research should be continued for better tools. GRAPPA neural recommendations are developed by international experts and can assist rheumatologists in daily clinical practice. Who are refractory to TNF therapy, JAK inhibitors should be considered, and apremilast is phosphodiesterase 4 inhibitor is also approved for treatment of psoriatic arthritis. Thank you for your patient hearing.
Thank you, Dr. Bhattacharya, for the wonderful presentation, and a special thanks for ending the presentation dot on time. When we joined the railways in the 1980s, Dr. Runa Mukherjee was the last word in the Department of Medicine in B.C.Roy Hospital. And I'm fortunate enough to be here during this oration that is given in our name. And I'm also very happy that it is, I'm told that last year the oration was delivered by Dr. Sharvani Shengupta, and she is the teacher, and one of her students, Dr. Paramita, she is delivering the oration this year, and it speaks volumes about the training, DNB training given in this hospital. And as PCMD of this railway, that I expect that in future many of our students will scale greater heights and make this institution proud. Thank you.
Thank you so much. I thank on behalf of the Department of Medicine to our PCMD and also to our DG RHS for appreciating the work. And thank you, Paramita. Thank you so much. It was really a wonderful presentation and within dot and time.
Thank you, ma'am.
Thank you. Since it was an oration, if normally it's not allowed. If you want.
Anyway, as an exception, one question is allowed.
First of all, the topic was psoriatic arthritis, not rheumatoid arthritis. And due to constraints of time, within 10 minutes, it's very difficult to explain the immunity and immune mechanism.
Should be another topic.
Yeah, another topic. Thank you for the question. Thank you so much. Interesting.
So I now take the privilege of requesting our chairpersons to kindly present a memento to our speaker, Dr. Paramita Bhattacharya. And we take the opportunity of presenting memento to Dr. Shorbani Sengupta. And thank you, sir. So we come to the last leg of our second scientific session, and that is oncology session 2. The topic, recent advances in radiation oncology and hands-on experience on Radiaxt X9. The speaker, Dr. Ayon Basu, a senior radiation oncologist of the city. He will be speaking on the subject, and the session will be chaired by Dr. Aniruddha Kirtonia, PCMD, Southern Railway. I request our speaker and our chairperson to kindly come onto stage and start the proceedings.
It's a great honor to chair a session sitting in front of Dr. Ayon Basu. No introduction is needed for him. He's the renowned radiation oncologist in the country, and he's one of the proud son of the soil of our place. Okay, over to Dr. Basu.
Thank you very much, sir. Respected Chairman, sir, and learned members of the audience. I would first of all like to thank the organizers for giving me an opportunity to speak before all of you and before such an august audience today. I'm a radiation oncologist by training, and I have had the good opportunity of having set up and installed multiple radiation oncology units all over the country and even abroad. And I've been the head of radiation oncology at different HCG hospitals, which are a chain of cancer hospitals, presently working in the Calcutta unit. So over the course of my career, I've had the experience of finding out that radiotherapy is imposing in terms of the technology that is involved, and often there's a lot of jargon involved in the practice of radiation oncology as it is done. And therefore, I will try to, over the very short span of time that has been allocated to me, dispel some of the myths and clarify some of the jargons that are associated with the practice of radiation oncology, which is one of the facets of treating cancer patients, one of the useful ways of local regional treatment for cancer, and dispel some of the myths which are associated with radiotherapy as it is done, and also talk about our experience of using a very new machine, a very advanced machine that has been installed for the first time in the country in our Calcutta unit here. So initially, right from the late 60s and 70s, radiotherapy was basically, the idea is very simple. It is about completing the job that a surgeon does when he removes a malignant tumor from the body by clearing off the cells which the surgeon cannot see. So there are cells which are left behind outside the gross tumor, which are not identifiable on any some form of imaging, which basically the radiation oncologist helps clear up. So it's a part of the loco-regional armamentarium for the management of cancers. And the rest of the job for killing off the cancer cells which have already disseminated in the bloodstream or in the lymphatics is done by the systemic therapy, either hormonal therapy for breast cancer and prostate cancer, targeted and immunotherapy nowadays, and of course systemic chemotherapy, conventional chemotherapy as has been applied. So usually a multimodality management used in the treatment of cancers would involve a combination of loco-regional treatments like surgery and radiotherapy and systemic therapies, be it chemotherapy, hormone therapy, or immuno and targeted therapies. Now, the radiation oncologist basically completes the job of a surgeon. A surgeon, generally surgeries tend to have the best outcomes for locoregionally confined cancers, and radiotherapists basically complete the job that a surgeon does. In certain situations where it is inoperable, either because of medical comorbidities or basically the anatomy is such that you can get away with utilizing surgery only for the biopsy or the initial histopathology or the diagnosis, in those cases, radical radiotherapy with or without concomitant chemotherapy can also be used to cure a cancer patient. And radiotherapy is also one of the most effective tools for palliating either a bleeding or brain metastases or painful bone metastases for advanced cancers. So radiotherapy has multiple uses in the armamentarium. But then the idea of delivering radiotherapy is basically, again, trying to hit the cancer accurately and limiting the dose to the surrounding normal tissues. This, over time, has used a lot of radiological imaging, particularly involving axial imaging like CT scans, MRs, and of late PET CT scans, and use of particle accelerators or linear accelerators, and therefore uses a lot of technology. And generally, doctors are intimidated by use of very advanced technology. So was I when I started my career as a radiation oncologist. And but then, I mean, when you start the practice of radiation oncology, you realize that even back in the 90s, this is almost magical. The painting, the very famous painting on the left, was instructed to be reproduced to a modern linear accelerator. What was a modern linear accelerator in the 90s with 1 centimeter wide leaves, with the use of computers. And the third image from the left is what it achieved. So you can well understand how accurate radiotherapy would have become over the course of the next 3 decades as we practice it today. But the problem is, targets or cancers or the area that you're trying to hit with radiation doesn't remain fixed. It moves around, and even a kid knows that. So it is important to be able to see what you're trying to hit. And the extreme example is the Saharan desert ant, which manages to cross the entire Saharan desert just based on the topography. So seeing the tumor while it is moving around helps hit the tumor accurately, and therefore increases the outcomes and the results of radiotherapy. Radiotherapy hits tumors which move around within the body, both during the delivery of the radiotherapy and in between the treatments also. And radiotherapy, as you know, most courses of radiotherapy happen 5 days a week typically, for maybe a month or a little more than a month or so for curative intent. For palliative intent, it is usually a shorter course, typically for a week or less than a week. But in any kind of scenario, multiple courses of radiotherapy, multiple treatments of radiotherapy, which we typically call fractions, are delivered. And if the tumor is moving around in between these or even during the delivery of the radiotherapy, then it becomes a problem. Well, what has happened of late is that we have very good documentation about what sort of movements happen in individual organs and different areas of the human body. And therefore, we have both rotational as well as translational movements of each individual organ well documented. And therefore, margins have been fabricated around these organs so that we radiotherapists can hit the target with better accuracy. However, it also means that in order to encompass the tumors with these range of movements, we tend to treat larger volumes and therefore expose the surrounding normal tissue to a relatively higher radiation dose, which results in undue toxicity. And the objective of being able to have a clear visualization daily before treatment is what has been one of the most recent advances in radiation oncology, which allows us to decrease the normal tissue doses. A normal CT scan, for example, if a patient is breathing, and we are talking about a lung tumor, let's say, then it fails to locate either the size or the dimensions or the exact location of the tumor if you take it. So if you take it on a normal CT scan. So a classic CT scan will not accurately represent the exact dimensions, the exact size, or the shape of the tumor. So we need something that visualizes the tumor every day before delivery of the radiotherapy, which basically means incorporating a CT scan into a linear accelerator machine because of changes like these. So there are both rotational movements that we see on a daily basis if you have a linear accelerator which is equipped with a CT scan. And you can also see that there's a bending of the spine and other such movements happening on a daily basis. And if you don't correct for that, you either risk missing a part of the target and therefore having leftover cancer cells from where the recurrences might happen, or you might end up trying to cover that and increasing the dose to the normal tissue surrounding the tumor and thereby ending up with larger toxicity. We also have, if you have a CT scan and a software which can drive the machine and modify the plan on a day-to-day basis, then what we can have is called adaptive radiotherapy, which adapts the plan based on the CT of the day or the location, size, and shape or dimensions of the tumor every day before the delivery of radiotherapy, or at intervals as the radiation oncologist might select. So essentially all it requires is the ability to acquire CT scans on the linear accelerator machine which delivers radiotherapy, and the ability to alter the treatment plans to account for changes in the target shape, location, and dimension. So there's also something where you can use the same CT scan to actually back project the rays and calculate the radiation dose that has been delivered every single day to the tumor, and also the dose to the surrounding critical structures. Now, if you can quantify and add up these doses, it helps you to stop at any point of time and back calculate and see whether you are exceeding the dose to any of the surrounding critical structures, which can result in toxicity, or you can see if you are actually underdosing the tumor, which might result in a recurrence. So this is also one more way of adapting the radiotherapy, called dose adapted radiotherapy. You can also use the information that we can obtain from metabolic imaging like the PET scan to identify those areas within the tumor which require a slightly higher dose because they have a higher tumor burden in order to kill off all of the cancer cells. This is also known as serognostic adaptation, which is PET-based adaptive radiotherapy. This is a typical PET scanner which we use for radiation planning. This is a machine that we have been using at the Calcutta unit of our hospital. This was the first such machine to have been permitted by the Atomic Energy Regulatory Board, which regulates all radiotherapy machines. This looks more like a CT scanner, and it has got an automatic segmentation software, which basically eases the job of the radiation oncologist in leaving us only to identify the tumor and the area that we want to treat, because rest of the body anatomy is identified by the software itself. It is also very good in adapting the radiation treatment based on the daily CT scan that it requires just before the radiotherapy delivery on each treatment. And it also, in those cases where there is a recurrence and we are talking about a second course of radiation, it helps us see the effects of the previously delivered radiotherapy and the ongoing radiotherapy cumulatively, which keeps radiotherapy safe. It helps us tackle these kind of scenarios where you have bilateral breast cancers, where we are trying to protect the heart and both the lungs while still treating the chest wall and the supraclavicular and the axilla on both sides. Very complicated cases for a normal linear accelerator machine. We do a lot of bone marrow transplants in our hospital. So some of the cases where there is no visceral involvement, where the liver and the spleen are not affected, we can get away with doing treatment of the bone marrow alone as a preparatory regimen for the transplant. So it requires what is known as a total marrow irradiation, and this is one of the only machines in the world which can actually do that. And this is a typical TMI or a total marrow irradiation that we do. The commonest childhood tumor, brain tumor, is a medulloblastoma, as you all know. And in medulloblastoma, because it has a CSF dissemination, we tend to treat children to the entire thecal space or the entire CSF space. And it's a very complicated treatment in a small child. It's very difficult for the child to tolerate. And if you have a scenario like this on this machine, it is very easy to deliver a craniospinal irradiation, which is again one of the very challenging techniques of radiotherapy. Pineal gland tumors, etc., and multiple brain metastases are also very well treated on this kind of a scenario. In spinal or vertebral metastases, we can protect the dose to the spinal cord and prevent transection-like syndrome, whereas still treating the vertebral body with adequate doses of radiotherapy. This is the first publication on helical tomotherapy from our country, because the first such machine was installed in 2007 in Tata when I was a resident under Dr. Tejpal Gupta. I am very fortunate to have my name here. And this is the third generation of the machine is what we use today. Thank you very much for your time and attention.
Thank you, Dr. Basu, for your lucid presentation. The paper is open for discussion. Any takers? I think there is no question. Everything is explained. Okay, please.
PEGF is basically vascular endothelial growth factor. वो एक तरह का मार्कर है, कुछ कैंसर सेल्स में पाया जाता है. उसके अगेंस्ट में ड्रग्स है जैसे बेवासिजुमैब, और वो केमोथेरेपी से संपर्कित है. मैं रेडिएशन ऑन्कोलॉजिस्ट हूँ, तो इट्स अ लिटिल आउट ऑफ कॉन्टेक्स्ट. Sorry, I didn't get your question. You are a civil engineer, you said. I respect your oncology opinion, however, I don't agree with it. Thank you very much.
Thank you.
So I take the privilege of requesting our chairperson, Dr. Aniruddha Kirtonia, for presenting a token memento to Dr. Oyan Basu. Thank you, sir. And we come to the end of this oncology session. And before we close today evening's program, we have a panel discussion on the cards. The topic, a very common topic, diabetic complications, how to approach. The moderator, Dr. Shormishta Mukhopadhyay, and the panelists of this evening's discussion, Dr. Rana Bhattacharya, Dr. Basudev Bhattacharya, Dr. Bhaskar Ghosh, Dr. Biplab Banerjee, and Dr. Shayantan Shaha. I will request all our panelists to kindly come onto stage, and to Dr. Shormishta Mukhopadhyay for moderating the entire session.
May I have a chair, please? চেয়ারে বসে অপারেট করা যাবে না আচ্ছা ছেড়ে দাও না তাহলে দেখতে পাবে না লোক থাক Good afternoon, everyone. So this is the ultimate session of today, a panel discussion on diabetes. Although the population is very less now, I think diabetes is such a common subject and most of us are interested in it. Even might be that in this hall also many doctors are there who are diabetic. So I would request everyone that to have a nice interaction, please come forward. It will be my request to everyone. Then at least we will be encouraged if you are not. So can the back seaters come forward, please? Is Dr. Biplab Banerjee there? Where is he? So it's okay. Since we have a running short of time, so I may discuss it. I may start our discussion. Basically, I have kept it as a case-based discussion, and I would like to ask to the audience that after the case is projected in the here in the on the screen, the audience would interact fast if they wish, and then we have our experts, 5 expert doctors with us, who will then give their expert comments. Another Dr. Biplab Banerjee will be joining us very soon. So this is our first case. To the expert for this case is Dr. Shantanu Shaha, and of course the others may also comment if they want. So a 14-year-old male diagnosed as type 1 diabetes mellitus at the age of 10 years, reads in class 9, on basal bolus insulin regime, regular thrice and glargine at night, comes with an SMBG record, that is self-monitoring of blood glucose record, of fluctuating glucose level, many hypos and hypers. Main complaint of the mother is dietary irregularity. There is occasional history of missed dose during school time because he is taking 4 times a day. He takes parts in school sports but had episodes of hypos, and he also complains of recent weight gain. So this is the SMBG chart. You can see that in the weekdays, actually only fasting and night sugars are monitored, and at Sunday and on Sunday and Saturday, the pre-lunch and post-lunch are also recorded. In Sunday, Saturday, there are more or less normal, but in weekdays, in pre-dinner and post-dinner are sometimes very high. There is one pre-dinner low level of blood sugar too. So what is the, anyone can comment, how can we manage the diet? The patient is having a irregular diet to this patient. This is our practical problem, nothing very at the molecular level or scientific, many scientific things are to be ascertained. But only the thing is that who manages patient, they can tell. So any suggestion from the audience, how the diet can be proper in this patient, and how will we advise about exercise, because the patient is gaining weight, and when he goes for exercise or any sports activity, he has hypoglycemia, so he is refraining from exercise, and how to manage the fluctuating glucose. Any suggestion from the audience? We don't have the PGTs here.
Yes, ma'am, we have PGTs.
Any PGT? If no one wants to interact, we have short of time. So, Dr. Shaha, will you please suggest?
So this child was diagnosed to have type 1 diabetes and was on treatment since 10 years of age. Now, at the adolescent period, as the mother also gave the history that there is skipping of the doses and also the meals are often he skips the meal. So there is a fluctuation of blood glucose and also the fluctuation, also the hypoglycemic episodes with the exercise or school sports, college sports. So the dietary advice that should be the patient education is very important about the diet, and he should be educated not to skip the meals. As with the change of his schedule, the long classes or tuitions, there may be skipping of meals or the doses of the insulins. So the adequate calorie intake and also the spacing of the meals is very important, and he should not skip the doses. And whenever he skips the doses, then the diet has also to be adjusted. And there are few episodes of hyperglycemias also, maybe some snacks which may be very calorigenic, like some junk foods which may be taken at this age, that may cause these hyperglycemic episodes. That should also be counseled. Glycemic control is very important. And regarding the exercise, that the child is gaining weight at this age, so the exercise after the proper calorie intake, that should be encouraged, but heavy strenuous exercise, that should be avoided to avoid the hypoglycemic episode. And also the excessive exercise may also cause some hyperglycemia sometimes. So the balance of calorie intake and also the exercise and also the meticulously the drug administration, that is also important at this.
Very well said, Dr. Shaha. Few points I want to add, that for a child of 14 or 15 years, we should not be very strict. If he wants to take biryani on one occasion in any birthday party or one piece of birthday cake, we will not discourage him or her, but it should not be the rule. In majority of time, he or she should be adherent to the diet, but for one or two occasions he or she may miss the proper diet, and maybe we may give to certain liberties also. And for the hypos during exercise, we can have adequate carbohydrate intake before the exercise. And also, if the exercise duration is more than 1 hour, then in between exercise also some sort of carbohydrate may be taken. That is one. And if it is tight controlled, then hypos will be there. And if it is not tight control, if it is uncontrolled, then during exercise even diabetic ketoacidosis may also happen. So these things should be kept in mind. And regarding fluctuating blood glucose level, as these patients can take some some snacks in between. So rapid acting insulins or ultra rapid acting insulins will be very much useful for them. They can even take a very short amount of insulin, say Lispro or Aspart, during the evening snacks. So with this, I'll shift to the next case, which the expert of this case is Dr. Rana Bhattacharya, a 58-year-old lady, type 2 diabetes for 7 years and hypertension for 10 years. I think our beer Singh wards are full of this sort of ladies. On conventional premixed 30/70 insulin 25/15 and metformin 1 gram, telmisartan 40, cilnidipine 10 milligram BD. She comes with bilateral pedal edema and facial puffiness, with normal blood pressure, no clinical evidence of pleural effusion or ascites, with a normal hemoglobin, creatinine borderline high, with a EGFR of 41, and with normal TSH, and albumin is very low, 1.9, whereas urine ACR is 8 gram per day, and it is repeated after 2 weeks, and that revealed 5.2 gram per day of urine albumin. So definitely it is in nephrotic range proteinuria. And other parameters like ECG, echocardiography, fundus are normal. USG KUB showed no evidence of chronic kidney disease, and you can see the size of the kidney here also. So how will you approach to the case? to Dr. Rana Bhattacharya. If audience can wants to give any comment, please, it is encouraged. Your comment is welcome. Anyone from the Department of Medicine? Yes, Sharbanidhi. Nephrotic range proteinuria in a long-term diabetic patient. This is a prototype case. We see every day this type of case. In fact, one of our patients, if our PGTs were present, they could see one of such a patient was admitted in our ward, say 1 or 2 weeks back. The patient's name was Champa. I have taken this case from
Yes,
her
many
history
of
only.
many a time we come across these sort of cases, and before I think with a normal blood pressure and no clinical history of any other serositis, this patient with a high thyroid level also normal, only T2DM and urine ACR is very high that we have to I think before referring to Rana, we need to do a 24 hours urinary protein. 24 hours urinary protein and investigate the patient whether she has any other
Yes.
associated comorbidities or not.
That is the most
So-
important thing,
Yes,
because the patient nephrotic range proteinuria is how much common it is in diabetics per se. My question to Dr. Rana Bhattacharya.
Well, Acha, should I discuss this case one by one?
Yes, yes.
Number one, a 58-year-old lady doesn't mean anything. Secondly, it's type 2 DM for 7 years and hypertension for 10 years. This is not the usual story. And this should give some clue because the story is usually reversed. First diabetes, then hypertension. But here we are finding that the patient is a hypertensive for the last 10 years and diabetic for the last. Diabetes doesn't cause hypertension doesn't cause diabetes. Rather, diabetes leads to hypertension. This point gives some clue. Number 3. A patient is on while patient is on mixed insulin and metformin, telmisartan, very good medicines and clinidipine and all, comes with bilateral pedal edema and facial puffiness. These two features can be found in various conditions. It could be found in in heart failure, congestive cardiac failure. It can be found in renal failure. It can be found with anemia. It can be found with hypothyroidism. So many and so forth. So this doesn't give away anything. BP is normal, and there is no serosal collection. The hemoglobin is 10.2. Okay, fine. The creat is 1.4, and the EGFR is 41, which is stage 3B. Stage 3B, CKD, stage 3B. Then thyroid is okay. The total protein signifies that the albumin is very low. Now, ACR is 8 grams per day, and this is repeated after 2 weeks, and it comes down to 5.2. Sharmishta, my question is that, how did it happen? Was it, it could have been due to the drugs, the telmisartan, clinidipine, or some amount of protein restriction, something, salt restriction that could have led to the lowering
As
of.
it is a real case, I may say that the patient's urine, I have not written here, but the patient was suffering from UTI. And the
UTI, okay.
urinary tract infection was corrected,
So
but
the-
still then the patient's, the albumin level is too high.
So
Very
that
clear-cut
explains
nephrotic
that explains the high
Yes.
protein.
Yes.
Then ECG echo normal. Now the giveaway, like in Dadagiri show of Saurav Ganguly, the googlies are given. So this is the giveaway. Fundus is normal.
Yes.
This is a giveaway. The hypertension is a giveaway. So this, the CKD size, etc., normal. These are all okay. So this is classically NDKD.
Yes.
This is non-diabetic kidney disease. So we have to, just because a patient is diabetic, we should not stamp him or her as having diabetic kidney disease. In fact, if diabetic retinopathy is not present, in 50% of cases, it may not be present. But in type 2 DM, It is present in more than 80% of cases. So we have to think for others. Some glomerulonephritis, it could be glomerulonephritis, it could be multiple myeloma, it could be some other things, so many other amyloidosis. It could be because the kidney size is normal. So it could be jolly well multiple myeloma, it could be jolly well amyloidosis, it could be so many things.
That was actually the focus of our case.
Yes,
That kidney disease in a diabetic patient does not mean that it is always diabetic kidney disease. So we have to remember that there is an entity called non-diabetic kidney disease, which may be present in diabetic patients too. So when these sort of findings are present, like fundus is normal, there is hypertension, there is, other parameters are almost normal, and with such a high range of proteinuria, we should definitely think of those causes what Dr. Bhattacharya has already enumerated: myeloma, kidney, the amyloidosis, and we should proceed and all those focal sclerosing glomerulonephritis and membranous glomerulonephritis, etc. So what will be the the investigation of choice in the inpatients?
Investigations of choice, like we have to think in terms of the other diseases that I spoke about. So towards that end, the blood investigation should also include the vasculitis panel. We should also look for abdominal fat pad biopsy, which we are doing regularly in our hospital, to rule out for Congo red stain, to rule out amyloidosis. And if everything is, if it is multiple myeloma, we have to go in for a kidney biopsy also, provided all the parameters are okay. So only then we could arrive at, if the glomerulonephritis, only a biopsy can tell us what is the stage. So all the, even there has been some blood investigations, some invasive investigation in the form of renal biopsy, and serum protein electrophoresis to rule out multiple myeloma. All these things have to be done.
Very, very well taken. So I'm moving to the next case, where the expert is Dr. Bhaskar Ghosh. Is a very common case. We face these sort of cases every day. A 45-year-old lady, type 2 diabetes for 8 years, on metformin 2 gram, glimepiride 2 milligram, pioglitazone 15 milligram, initially poor control but later improved, comes with progressive weakness of all 4 limbs in an ascending manner, that it starts from both the lower limbs and gradually it affected upper limbs too. Mild sensory symptoms were there without any bladder bowel involvement. On examination, there were distinct clawing of feet and atrophy of calf muscles, also atrophy of dorsal interossei of hands. So there are certain motor involvements are there in the form of wasting. Pain, touch, temperature is preserved. There is loss of vibration sense. Romberg's test was positive with a bilateral flexor plantar reflex. And HbA1c is slightly on the higher side, 7.2%, creatinine normal, and no evidence of retinopathy. So how to approach this case? Anyone from the audience? Paromita? No. Anyone? Again, Shorbanidi? Ongida? Then probably we, Dr. Bhaskar Ghosh.
I will ask the audience that what is the classical presentation of diabetic neuropathy.
Exactly.
That will solve the problem. So actually what I feel, Sharmishta is bowling spin bowling and giving a lot of googlies today. So the very difficult to stand with a bat. So can anyone now volunteer?
What is the classical feature of commonest type of diabetic neuropathy? What is it?
Actually,
yes?
Yes, Paramita, please.
Yes. So peripheral, symmetrical, peripheral sensory motor polyneuropathy with sensory predominant.
Actually, classical feature of diabetic neuropathy is there is pain associated with loss of sensation. So this is controversial. In one side there is loss of sensation, another side there is pain. Because in classical diabetic neuropathy, there is involvement of the small fibers, both myelinated and unmyelinated. But large fibers are relatively spared. So because small fiber, they are associated with pain, temperature, sensory, the hot and cold sensation like that. So patient has got severe pain as well as loss of sensation. So this is the classical feature of a diabetic neuropathy: distal, symmetrical, sensory or sensory motor neuropathy. Now, a patient having predominantly motor, as in this case, there is barely any sensory symptom, and what he has found out is objectively that there is loss of vibration says, because patient will not complain to you that I am having loss of vibration says. Rombar patient will also not tell, because it is a test what we do. So classically, this patient has a predominant motor neuropathy, and this patient came to me about 10 days back to my chamber. With 2 years, he has been treated with several anti-diabetic and several painkillers, but with no relief, and he is going downhill. So I immediately sent the patient for nerve biopsy and ancillary investigation, and it was found to be a case of CIDP. So one has to remember that in diabetic patient, as Rana has already said, 50% cases, rather I should say 10 to 50% cases are due to, in patients with neuropathy, 10 to 50% cases are not due to diabetic neuropathy, but there is some other causes there. So what are the other common causes? The one most important one is CIDP, because the CIDP means chronic inflammatory demyelinating polyradiculoneuropathy. So this is the autoimmune condition. So this is more prominent in patients with diabetes, because diabetes itself is a immunocompromised state or altered immune state. So CIDP is more common in diabetic patient than in general population. So CIDP, you should always remember that patient presenting with dominantly motor symptoms, one should think of this. Number two, there is, as you know, the patient is on high dose of metformin. So metformin causes vitamin B12 deficiency, but that too, vitamin B12 deficiency usually produces deficiency syndrome. So deficiency syndrome usually produces severe pain. So they have got severe pain, tingling, numbness like sensation in B12 neuropathy. Still one has to think about it. One has to think of this alcoholic neuropathy or exposure to other toxins, and there are certain other less common causes. So whenever you see such a patient, you should think about this. Now, I will just say about a few other things that diabetes can affect. Also, there's autonomic neuropathy. So there will be sexual dysfunction, there will be urinary dysfunction, and it can also affect truncal neuropathy. Patient may present acute abdomen-like symptom because of truncal neuropathy, and they can present with this asymmetric, predominantly painful sensory motor plexopathy, that is called diabetic amertrophy. So and that is a very severely painful condition. Patient will break your head with pain. So it is usually one-sided proximal involvement of the lower limb. Sometimes it can be also involvement of the upper limb, and also there may be sometimes this Guillain-Barré like presentation, but they are almost rare.
So very well taken, Bhaskar. Actually, our classical teaching was like that in a diabetic patient, if predominantly motor signs are present, then only we should do EMG and NCV. Sometimes for constraints of price due to cost benefit, I mean, due to the high cost, sometimes we may avoid classical NCV in classical diabetic neuropathy patients. But if there is any sign of this clawing, this atrophy and wasting, predominantly motor type, we definitely go for EMG and NCV to exclude CIDP, because that is a treatable case. So how to treat, if you can add just one sentence, because there are more cases.
Actually, I purposefully omitted electrodiagnostic part. In electrodiagnosis, in diabetic neuropathy, it may be normal also, or there may be predominantly sensory motor neuropathy. And in case of CIDP, there is, and it is mostly axonopathy in diabetes.
Yes.
But in CIDP, it is predominantly demyelinating type and sensory motor polyradiculoneuropathy. And you can have elevated CSF protein with normal sugar, that can be thing. And the treatment is mostly, if you can prove that you are dealing with a case of CIDP, it is IVIG or plasmapheresis is a drug of choice. And there are lots of cases in our hospital also. So Mr. knows they have improved after this sort of therapy. And you also look for cancer. That I tell you, that is also a cause of neuropathy.
Yes, that is very important. Okay, moving to the next case. This is actually a pair of cases, and our expert in these cases is Dr. Basudev Bhattacharya. So the first case is a 39-year-old woman, type 2 diabetes for 1 year, hypertension for 5 years. Routine checkup shows HbA1c 6.6%, creatinine normal, LFT normal. Her lipid profile shows cholesterol 180, triglyceride 200, LDL 104, HDL 36, lower level, VLDL 40. So she is very much worried about this raised triglyceride and low HDL. So what will be our message to the patient? Vasudevda.
Actually, this young lady is hypertensive and recently diagnosed diabetes. So as because he has got a CV risk factor, CV risk factor, the two risk factors. So we are more be attentive regarding his LDL level. So it's supposed to be within 70 to 100 milligram. And triglycerides is slightly high, but most of the cases, just lifestyle modification and dietary modification can reduce that triglycerides by 50%. And one thing I need to, I think it need to be mentioned, that treatment of triglycerides per se does not decrease the CV risk.
Yes.
So up to 500 milligram of triglycerides, if needed, we should use statin. And when the triglycerides is more than 500 milligram, then we should use fibrates, because it causes, there is a chance of pancreatitis. And when you use fibrates, you must take care of the creatinine, because when in a regular use of fibrates can increase the creatinine level.
Hypercreatininemia. So that is a very important message, I think, that we should not be worried about triglyceride. Rather, a small increases LDL is more worrisome than to treat a triglyceride. We should treat triglyceride only what Dr. Bhattacharya has said, only when the level is very high, around 500 milligram per deciliter, to avoid pancreatitis, not to reduce CV risk. So coming to the second case, a 65-year-old man, type 2 diabetes and hypertension for 10 years, on glimepiride 4 milligram, sitagliptin 100 milligram, metformin 2 gram, amlodipine 5 milligram, and atorvastatin 20 milligram. The patient complains of effort intolerance. He has an HbA1c of 7.3%. Echo shows normal LV ejection fraction with diastolic dysfunction with NT-proBNP of 600 picogram per milliliter. His lipid profile shows cholesterol quite raised, 236, triglyceride 160, LDL is 164 even on treatment of atorvastatin 20 milligram, HDL 40 and VLDL 32. So how to approach this patient? There are actually two issues. One is the effort intolerance and second is the altered lipid profile, still high cholesterol even after using atorvastatin 20.
So here is an elderly person with a long-standing diabetes and hypertension, presented with shortness of breath, with normal LV function, LV systolic function with diastolic dysfunction, and raised proBNP. So this constellation suggestive of diastolic or heart failure, HFF, heart failure with preserved LV function. But before that, we have to exclude the other disease which mimics heart failure. That's just like the exacerbation of COPD, deconditioning, and anemia. We have to exclude this thing. So how do you diagnose the HFF, heart failure with preserved LV function? The rules are that the LV function, ejection fraction should be more than 50%. There will be diastolic dysfunction with increased LV filling pressure. You can do it by echo. I mean, echo is a commonest tool for the diagnosis thing, and along with raised proBNP. So what is the cutoff level of the proBNP? It is classically is 125. It is for the normal person. And the obese person, the level is 50% less. That's around 62.5. That is you should remember that the obese patient, normally the proBNP level remains less than the usual person. So what should be the treatment to this patient? So diabetic, HFF was one of the frustrating kind of disease, but very recently, within last 2 years, we have got an effective medicine we have found over here. That's the 2A indication is the SGLT2 inhibitors. So this is the first line drug for controlling of the HFF. Obviously, along with others measure with dietary measures, salt restriction, etc. And along with that, we have used loop diuretics if the patient is volume overloaded. Other drugs that just like MRA or I mean Vimeda is these are 2B indication because there is all the trials showed that there's not a significant amount of improvement using MRA or RD. And beta blockers has got a really very minimal role in management of diastolic heart failure. And what
actually, this patient is not getting SGLT inhibitor, SGLT2 inhibitor.
Yes.
He is getting all other drugs, but the
But
most
not
important
SGLT
drug
inhibitor.
he is not getting. That is the focus.
So actually, right now it has been found in, retrospective trial, that retrospective observation that in the hospital admission, 42% patients are admitted with diastolic heart failure and only 40% are admitted with the systolic heart failure. That is the peculiarity.
All diabetic patients have diastolic dysfunction and grade 1 fatty liver.
Yes.
This is almost a dictum
And,
nowadays.
the phenotype of the diastolic heart failure is a hypertensive, elderly, male female, diabetes, obese, and atrial fibrillation. So these are the constellation where we can have this thing.
Bashuditya, what is your take on atorvastatin 20 milligram?
Yes,
In spite of
atorvastatin
that,
20
LDL of
So
164.
as because he's a high risk patient, so we have to keep the LDL level less than 55.
Yes.
So there is an algorithm, simple algorithm, that you have to use highest possible level of statins, that is atorvastatin 80 milligram or rosuvastatin 40 milligram. If you don't achieve the goal, you add ezetimibe 10 milligram. If not, then you add bempedoic acid 180 milligram. These are the protocol which are available here. But if even it is not controlled, then we go for the PCSK9 inhibitors.
Yes.
These are the actually protocol, we have to use it.
So that is the algorithm. Yes. Bhaskar is asking some question.
What I am asking you is that patient has got effort intolerance, and as you know that patients with diabetes may not have chest pain. So would you
Yes, we
advocate
are
in this
one
case
thing I
coronary
forgot to-
angiography?
yes, absolutely forget that patient should go for angiography. Definitely. Actually, I forgot it. Aspirin what for? He needs aspirin. Obviously, this patient, all the patients, has a multiple, severity risk.
He is
So
not.
he
He's
must
not
have,
taking.
he must have aspirin,
Okay.
definitely.
What is your strategy when the patient has got statin intolerance? Because such a high dose of statin may cause some
Yes,
myositis
yes.
and also some altered LFT. So what will be your...
When there is some statin intolerance, especially the myalgia, so it has been found that you look for the vitamin D deficiency. If there's a vitamin D deficiency, if you can correct, the myalgia may improve. And another is the hypothyroid.
Yes.
So whenever the statin is not available, then we have to go for the alternate therapy. But only the statin which can reduce the dose, but you can reduce the dose of statins like 20 milligram or 10 milligram whatsoever. But and along with this, we have to use all these ezetimibe and bempedoic acid. Because the only statin which can reduce the LDL level by 50%, and only other drugs are 15 to 20%.
Yes.
So it's a synergistic effect. And obviously, the best thing is PCSK9, but it is extremely expensive.
Extremely expensive. So we have to
Can
first
I have
exclude hypothyroidism and hypovitaminization.
Yes, that should be excluded when there is a myalgia.
Yes, yes. Chumkidi, please. Yes.
Now, as such, kidney failure doesn't causes
COPD may cause
and doesn't
also
causes protein. When the protein will be elevated, when there's a high filling pressure in the atrium. So when the CKD patient has got a fluid overload, then naturally there will be increased filling pressure. That is the cause of diastolic heart failure. The CKD is one of the cause of diastolic heart failure, or HFpEF. CKD is one of the cause of HFpEF. So HFpEF, by definition, it is the different phenotypes. CKD, hypertensive, obese, atrial fibrillation.
The reports which are not mentioned here is actually for due to constraints of time, it is actually normal. So coming to our case 5 to Dr.
I
Biplab
have a
Banerjee.
question. I have a question.
Pardon?
I have a question to ask.
Huh,
I know this is a diabetic session and an endocrinology session, but I am missing out on all the chest X-rays here. So because the NT-proBNP is high, I think this patient deserves to get a chest X-ray also.
Yes, I have told that those things which are not mentioned here are essentially normal.
Actually, just cut down the time and
Cut down the
actually,
time. Just
because there's no time for elaborate description over here.
Thank you.
So coming to Dr. Biplab Banerjee or any of the gynecologists who are in the audience, a 28-year, very common case, 28-year-old lady, primigravida, 20 weeks of gestation, both parents diabetic, history of diabetes in both parents, comes with a fasting blood sugar of 120 and 2 hours OGTT 202. So how to manage, how to approach?
Yeah, this is initial diagnosis. This is an GDM case. It is the first appearance is a GDM, number one. But number two, there is both the parents are diabetic, and I think she should have a HbA1c done, whether she was diabetic before the pregnancy and she is continuing now and it's detected now. So in this case, I will ask for an HbA1c report along with a TSH report, apart from the obstetric management. And then we'll consider the management for, in this case, with considering the BMI of the patient, consultation with the nutrition specialist, how will be the diet, along with the metformin, I will continue, then recheck the blood sugar after 2 weeks, the fasting and PP.
Okay. Can you tell something about early GDM? Because early GDM is a term which is coming nowadays. In between this gestational diabetes mellitus and pre-gestational diabetes mellitus, we are now having a term early gestational diabetes mellitus. Can you say something about that?
Yes, actually, if the BMI of the patients are high, these patients should be always under suspicion whether they are having say, abnormal glucose tolerance or not. So they should be screened earlier.
Yes. So at the first visit.
In the first visit.
Yeah. So that is our take, that we should not wait for the second trimester when actually the classical GDM appears, but we should screen in Indian subcontinent. We should screen from the very first day, because India is a country where diabetes is very much predominant or prevalent. So coming to the next case, to Dr. Shantanu Saha, a 16-year-old female. It is also a case of both Dr. Shantanu Saha and Dr. Biplab Banerjee. She comes with menstrual irregularity with BMI 28, acanthosis nigricans present. There is no goiter, mild hirsutism. TSH is normal, but incidentally, the patient goes to pediatrician first because she was a patient of Dr. Shantanu previously. So before going to gynecologist, she went to Dr. Shantanu Saha, and with blood sugar level done, it appeared that fasting is 185 and PP is 272 milligram per deciliter. So what else investigations to do and how to manage? Very, very brief.
Actually, this is a patient just attained the pubertal age and also having menstrual irregularities, obesity, acanthosis nigricans. That is a sign of insulin resistance, and also hyperglycemia. So in this case, we should approach like that. We should also look for the comorbidities associated. At first, for the obesity part, we should counsel the patient on the diet, and on the exercise part, she has to undergo some exercises to reduce the BMI. And also we have to screen for the hypertension, and we should check for the age appropriate blood pressure, and it should be less than 95th centile. Initially, if the patient is hypertensive, we should avoid added salts and also the lifestyle modifications. And after 6 months, if hypertension exists, then we may add medications like ACE inhibitors. And also we should psychological counseling should be there. There may be at this age, at the adolescent age, there may be some eating disorders, depression or anxiety, and also due to some peer pressure, due to some body image related issue. These are also prevalent in this age. These issues also clinically to be evaluated and addressed. And also the possibility of PCOD, that should be ruled out. The ultrasound should be done, and also the hormonal evaluation if needed. And already the thyroid profile has been done here. So these issues should be addressed.
Yes, so type 2 diabetes is also very common nowadays in teenagers, particularly in our country. And it's more common when both parents are diabetes. There is a 75% chance of being the offsprings to become diabetic, and probably this patient has got associated polycystic ovarian disease, which is not yet evaluated. So moving to the next case very rapidly, again to Dr. Biplab Banerjee, just in connection to the gestational diabetes, 35-year-old lady with type 2 diabetes and hypertension, already diabetic before pregnancy. She is married for 1 year back, desires pregnancy, and she is on glimepiride, metformin, Vilda, olmesartan, and atorvastatin, with a fasting blood sugar of 132, PP 192, and HbA1c of 7.5%. And remember that this patient with a history of diabetes wants to become pregnant at an age of 35-year-old. So she visits doctor's clinic before planning pregnancy. And what will be the advice to the patient before planning pregnancy? Dr.
Actually,
Biplab
the
Banerjee.
concept of the conceptional clinic is not in our hospital, and also very few in our hospitals. The preconceptional counseling for all the patients, particularly the patients having the older patients, more than 35 years old, to AMH level, that is ovarian reserve, is already less. C is hypertensive and C is on olmesartan. That should be stopped before conceiving. C is diabetic on multiple oral hypoglycemic agent, of which metformin is only allowed. Otherwise, I'll have to control the blood sugar with appropriate insulin, and that with consultation with a diabetologist. Then with the HbA1c level is around 6 to 6.5, but important consideration regarding the BMI and AMH level. We next ask her to plan for the pregnancy and the appropriate method of induction that is required.
So that is a very brief and very to the point answer to approach to this patient. Definitely, we should omit certain drugs which may cause problem in pregnancy, particularly atorvastatin, olmesartan, glimepiride, vildagliptin, etc. Only metformin is allowed, and of course, the patient should be counseled for proper reduction of HbA1c. So coming to the next case. And also the retinopathy screening is very important before planning pregnancy, because during pregnancy
And
there
also
may
the
be
kidney status, because how long she is diabetic, nobody is known,
yes.
retinopathy and kidney.
So coming to Dr. Rana Bhattacharya again, a 60-year-old man, type 2 diabetes for more than 20 years, treated with OHA initially and insulin for last 5 years, with regular insulin thrice daily and poor metabolic control, complaints of generalized edema and dyspnea for 1 month. BP is high, 160 by 110, pedal edema is there, JVP is raised. There is evidence of bilateral NPDR, just in contrast to the previous case, and there is also auscultable pericardial rub and crackles at the base. The fasting blood sugar here is 249, urea 113, creatinine 4.2, EGFR 14, hemoglobin is 10.6. All other parameters are more or less okay. Cholesterol is 313 milligram per deciliter with a triglyceride 144 and so on. And ultrasonography shows evidence of bilateral medical renal disease. Serology is negative. So this is a typical patient of chronic kidney disease in diabetes, which we face in our duty to practice every day. So these are the sets of questions which are given to Dr. Rana Bhattacharya.
This is the routine bread and butter case for
Yes.
nephrologist. So any further investigations? Yes, a lot of investigations have to be done regarding an echo. I have missed out. Perhaps echo was done and all. Echo is important, and for the blood investigations, because the patient is more than 60 years old, we have to rule out multiple myeloma, because as per the KDOKI guideline, above 40, every patient with CKD must be ruled out for multiple myeloma. So that screening is important, and all these investigations almost they are done.
Please
Dietary
focus on
advice.
dietary advice because our
Dietary,
CKD patients,
yes,
they
dietary
say, I have
advice.
nothing to eat.
No, dietary advice is very, 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 very important. So I always tell my patients that the management of CKD depends on 5 Ds. The first is diet. The second is drugs. The third is doctor's visit. The fourth is daily exercises. And last comes dialysis. So dialysis is not the important thing. So diet is very important, and diet, every aspect, how much protein to take. If a patient is on dialysis, he has to take protein to the extent of say 100 grams per 100 grams per day. The sodium has to be, sodium salt has to be 2.3 milligram per day. Sodium, 2.3 grams per day. Then low potassium and low phosphate diet. Then diabetic 1600 kilocalorie diet and amount of fluid. This patient is already fluid overloaded, so we cannot give him more fluid. It has to be just 600 ml to 800 ml fluid. So there are a variety of drugs, a variety of diets which the patient, we have to talk to the patient, and if you are taking this, you cannot take this. So these types of
Can you give some idea about the vegetables and fruits which the patient
Yes.
can take?
Yeah.
Because they say we have nothing to take.
No. They can take say half apple per week, half guava per week. They can take lot of cucumber. They can take ripe papaya. Ripe papaya is very good, but not the unripe papaya. Ripe papaya is very good. They should avoid banana, citrus food. They should avoid coconut. And anything to do banana means every type of banana. Those in Bengali we call it thod, mocha, and all. They should avoid all those things.
Yes.
So that is absolutely to be avoided.
So there are certain low potassium fruits and vegetables also. So absolutely fruit is not that bad.
No. Fruit has to
That's
be,
the
because
point, huh?
because potassium is also important, because if a patient becomes hypokalemic, then patient will
And we see many patients to be
yes,
hypokalemic.
they
with
will have a
CKD
potassium of
background.
2.3. That is
Yes.
not done.
And please tell something about low phosphate diet.
Low phosphate means you have to stop drinking colas,
Yes.
additives, butters, cheese. You have to stop that. You cannot have junk foods.
Fish
Not to
bone,
be taken.
fish bone, and all those things.
Yes, fish you can take. Fresh fish. I always tell my patients, if you are a fish eater, you can go for all these carp fishes, rohu, katla, 800 grams to 1 kg weight, and you have to use little oil, 3 teaspoonful of
These
oil.
things can also be taken in moderation.
Yes, in moderation.
Yes.
Yes.
So what is your preferable antihypertensive in these patients? Patient-
Antihypertensive is such that should offer some renoprotection.
Yes.
So
The
there
patient's
are-
creatinine is 4.2.
because in any way renal hypertension is a very difficult thing to treat. So if a patient is following salt restriction and fluid restriction, the job becomes slightly easier. But clinidipine is very important. Clinidipine we have to
Clinidipine,
give.
yes.
Then beta blockers, metoprolol. Then another very good renal-friendly antihypertensive is minipress, prazosin. That has been shown to prevent apoptosis of renal tubular cells.
Yes.
So it's a renal-friendly medicine. And if nothing works, then there is always centrally acting medicines like arkamine and all those things. So you can always try that.
Okay. So preferable.
Yes. Leprosol, yes, always.
Preferable anti-diabetic insulin. The patient is getting regular insulin thrice daily,
Yes.
and she is poorly controlled.
Actually,
So can we add basal insulin? Because some people have the
Yes.
dogma that basal insulin cannot be added in renal failure.
In
because
fact,
they have-
I am dogmatic about that.
Yeah.
I am
Is it
dogmatic
really
about that.
so?
Actually, problem is that if we give basal insulin, these patients are so much prone to hypoglycemia
Yeah.
that we have seen.
See, if they don't monitor,
If
then
they
it will
don't
be-
monitor, it is very difficult to give long-acting insulin. Shormishta, I must tell you, because only 2 to 3% people regularly monitor, and otherwise these patients would not have come to the emergency with 23 blood sugar.
But this patient has got 249 milligram per deciliter blood sugar. So I think small amount of glargine can be added.
Why not? We can escalate the regular insulins.
So that will not control the fasting blood sugar to that much, I think. Anyway,
We can add SGLD.
That is
And
my point.
we can among the OHs we can add Pragenta.
Yes, so
Pragenta is one thing
linagliptin
we
and
can-
SGLT2
yes,
inhibitors.
we can
So
add.
for how much, what is the cutoff of giving SGLT2 inhibitors in a patient of CKD?
Actually,
EGFR.
Actually, we should be wary of this. This topic will be covered tomorrow, so I would not dwell into it because
Okay, that's fine.
না এইটা আমার কালকে আমাদের টপিকটা সেজন্য আমি
Okay, that's fine. Actually, up to 20 we can give SGLT2 inhibitors. So for
but
endocrinologist point of
why
view,
bother? We will give this Tragenta and all other medicines. that can be
linagliptin.
given.
Okay. So any
And
other
DAPA also you can give. No,
teneligliptin?
Teneligliptin no. DAPA is good. You can give Tragenta.
One thing is there, that is linagliptin reduces albuminuria.
Yes.
It has a positive action. Teneligliptin does not reduce albuminuria, but it is renal and hepatic safe. It
But
is
again,
safe,
but Shomishta, what will albuminuria do more in this case? Patient is already a CKD thing. If albuminuria can cause coronary artery disease, that is, you can, if you're stopping albuminuria, you are by default preventing coronary artery disease.
So when will this patient need dialysis?
Well, right now.
Yeah. So
Right
that's the
now.
point.
Because
Yeah.
One,
মাইকে যাও না, ওই যে মাইক্রোফোনে যাও না। না,
আরে এত আলো চোখে লাগছে না। আর কিচ্ছু দেখতে পাচ্ছি না।
Why it is preferable to give cilnidipine over and above amlodipine?
Actually,
this is a
clinidipine.
very good question. Very pertinent.
Clinidipine has got anti-proteinuric effect.
Exactly.
Anti-proteinuric effect. In patients with high potassium, like in this case, we would shudder to give telmisartan and any of those group of drugs because they will be landing up in hyperkalemia. So we are giving clinidipine. And
So, Dr. Biplab Banerjee was asking some question.
yeah, I'm asking about this. There is a puzzle of so many insulins, so many short-acting, Lispro, Aspart, all these are there. We're using for the diabetic pregnancy, or this patient is a pre-diabetic, diabetic before pregnancy. So we can control this with a long-acting insulin, what you were saying, this glargine or this group of drug. So what about the use of continuation of this drug during pregnancy? I know there is a chance of hyperglycemia, better for this night dose or control.
This Lispro and Aspart is well accepted for short acting. For long acting, we till a few days back also we used only NPH. Glargine has got some mitogenicity, so we usually used to avoid glargine. But nowadays, a few months back, degludec has been accepted after studies as a choiceable basal insulin in pregnancy.
and I take back my case from Biplab Banerjee. He jumped in the middle.
No, just one thing I want to
Again,
emphasize
Bhaskar Bose is jumping.
for the audience, that your most important is to control blood sugar and blood pressure. So choice of drug is secondary. So if you cannot control, as Sarvani has rightly pointed out, cilnidipine has several advantages, but blood pressure control is very
Blood
poor.
pressure control is very poor.
So
That is
I have seen patients are getting 40 milligram cilnidipine and blood pressure is too high, and just 5 milligram amlodipine, blood pressure 120 by 80.
But that will
So
increase the edema. Another thing
No,
that I want to say.
coming to your question, when will you start
I
dialysis?
have a few, just one comment, that if you escalate the dose of regular insulin, it will cause only nighttime hypoglycemia, but
Yes.
it will not control the fasting blood
I
sugar. If you
understand
don't add a few small units of
So
basal
6 units,
insulin.
8 units.
Yeah,
something like that.
that's the point.
So, and she was asking, like, when will you start dialysis? Which I said, I will start right now. Why? Because number one, there is pericardial rub. Number two, there is hyperkalemia.
Yes.
Number three, there are crackles. So patient is in heart failure. So I have to start. And in these patients, because this is a CKD patient, I would strongly advise the patient to go in for an AV fistula at the earliest, so that by the time he or she goes into regular dialysis, he will have the fistula ready. So that answers
Thank you.
my
So coming to our case 9, so we are proceeding rapidly. 65-year-old gentleman, type 2 diabetes, hypertension for 15 years, shortness of breath for last 1 month, on S-amlodipine, glimepiride, pioglitazone, saxagliptin, atorvastatin 10, and has a history of metformin intolerance, gastric intolerance to metformin. BMI is 32, The HbA1c is 6.5% with all other biochemical parameters normal. And ECG shows evidence of old anteroseptal wall MI, but there is no history of such MI from the patient. As Dr. Bhaskar Ghosh was previously told that these patients may have silent MI also. And echocardiography shows regional wall motion abnormality in anterior and apical wall with a LV ejection fraction of 35%. So we are now dealing with a patient, probably of a patient of heart failure with reduced ejection fraction.
So essentially, this patient is a ischemic cardiomyopathy with HFrEF. There is a chronic heart failure with reduced ejection fraction. So there is a two part of this discussion. Number one is cardiac management. For this thing, we go for the angiography and revascularization. And for the heart failure, I think just a few sessions before, it was been elaborately described the four pillar of management of HFrEF. One is beta blocker, another is ARNI, another is MRA, and before 2020, it was loop diuretic. Now it was replaced by SGLT2 inhibitors. Yes. So these are the four drugs that should be used for the management of HFrEF. Number one, and here we have to modify some amount of thing that here the blood pressure of this patient should be around 130/80. We should drop pioglitazone because it causes fluid retention.
Heart failure.
And
Also Saxa, I think.
Yes, saxagliptin
Saxa
also.
has also
Yes.
evidence of heart failure, hospitalization for heart failure.
So we have to modify this thing. We keep the blood pressure around 130/80, and obviously the LDL level should be less than 55. So for the heart failure is concerned, and the four pillars of the medicines is this ARNI, MRA, beta blocker, and SGLT inhibitors. And if necessary, you can use loop diuretic in between.
And also one thing you often use in your clinical practice, I have seen that correction of anemia by FCM.
Yes,
It
yes,
is
yes.
very, very
That
important
is
in
most
patients with
important
heart
thing.
failure, and
Yes,
Basiddar routinely
yes, it was
prescribes
that we have routinely go for serum iron, not ferritin, serum iron level. It is
Yes.
less than 50. We go for the FCM. Ferrous carboxymaltose, it was been found, there's lots of trial over this thing, that it is, significantly improve the systolic function in the cases of ischemic cardiomyopathy.
So coming to our last case, our expert is Dr. Bhaskar Ghosh. 56-year-old gentleman, type 2 diabetes and hypertension for 12 years, poor compliance and infrequent health checkup. He comes with sudden onset diplopia. Blood pressure is 148/96 with isolated left third nerve palsy with ptosis and ophthalmoplegia, but normal size pupil and pupillary reflexes are normal. So there is pupillary spared third nerve palsy, isolated third nerve palsy with a poor control of blood sugar, but RFT, LFT and electrolytes normal. So what is the possible diagnosis? Anyone from the audience? Not the seniors one. The juniors are not present actually. I cannot ask this patient to Shorbanidhi actually. How can I ask? She knows very well.
Now, this is a beautiful finding. Actually, a patient of diabetes presenting with a third nerve palsy. So, and you have to look for pupil. If the pupil is spared, so this is probably the cause is mostly medical cause. And if the pupils are involved, the cause is surgical. Why? Because if you think the cross section of the third cranial nerve, it has got a dual blood supply. One is inner core and another is outer core. So inner core, actually the pupillary fibers, they lie in the outer core. The inner core is supplied by vasa nervosum. That is that supply the inner core. And in diabetes, this cause of third nerve palsy is due to small infection in the vasa nervosum. So when the vasa nervosum will be affected, the inner core will be affected and there will be third nerve palsy. But the outer core, which is supplied by meningeal vessels, so they are spared. So the pupils will be spared in this case. Now, what is the commonest differential diagnosis? That is aneurysm of the posterior communicating artery. If think of the anatomy of the brain, that this third cranial nerve and the posterior communicating artery run side by side like this. So any aneurysm on the posterior communicating artery will compress the third nerve. And if the third nerve is compressed, the outer layer will be affected first, later on the inner part. So there will be pupillary involvement. So by looking at the pupil, you can differentiate whether it is a medical cause or it is a surgical cause. If there is a surgical cause, you should do it needs emergency intervention. But what I will advise, even if you find that a patient having third nerve palsy without pupillary involvement, you should also go for MRI angio and MRI brain to look for it, because it is not a 100% rule. It is a common question and common finding. So that's why it is always asked in the
But
examination.
in clinical medicine, nothing is like 2 + 2 = 3.
Yes, that's the
We
thing.
have to
But
do it.
to be on the safe side, you should go for MRI angio and MRI brain. Now, this, as I told you earlier, that diabetes can affect all nerves starting from brain, that is cranial nerves. Then it can affect truncal nerves. It can affect limb, plexus and radical, as well as neuropathy. So this is also cranial neuropathy is part of a diabetic neuropathy. And normally steroid is not given. It is not indicated. But if it is a isolated third nerve palsy, I mean without diabetes, you can give steroid. But if the patient is diabetic, steroid is actually not needed. It is actually a infraction of the third cranial nerve. Some patients give aspirin, are given aspirin. But with tight control of diabetes and with exercise, actually the ocular function returns to normal within 3 to 6 months time.
So steroid is not mandatory for these
Not
patients.
indicated,
Actually,
actually.
what we get in our clinical practice, that the patients already receive steroid from sometimes from neurologists.
That
also,
worsens
and that
diabetes.
worsens the diabetes control. They come with 400
Delay in
blood sugar level. Already he is 420. So that is the very good information which we have gathered from all our panelists. So we are at the end of this panel discussion today. Before ending, I must thank all the panelists, Dr. Shantanu Saha, Dr. Bhaskar Ghosh, Dr. Biplab Banerjee, Dr. Rana Bhattacharya and Dr. Basudev Bhattacharya for excellent discussion. And also I will thank our audience who have put up questions and who have discussed and put comments in this panel discussion. Thank you very much. And so I'm ending here. All of us will be ready for the dinner session. Thank you.
দেখে নিচ্ছি যারা পাইনি তো দিয়ে দিই ওদের, দেখে নিচ্ছি সর্বাণীতে কি যারা পাইনি ওদের দিয়ে দিচ্ছি মেমেন্টোগুলো। I'll request Dr. Sharbani Sengupta to kindly come forward and present mementos to our panel discussion members. Sharbani আসছে। Chalo. We would like to present mementos to a senior panel members, Dr. Bhaskar. I'll request Dr. Sengupta to present mementos to Dr. Bhaskar Ghosh, Dr. B.D. Bhattacharya, Dr. Biplab Banerjee, and Dr. Shayantan. Dr. Shayantan Saha. Dr. Biplab Banerjee. বিপ্লব ইয়ে পায়নি তো, ভিডিও তো ভাস্কর ঘোষ, 7 জন লোক।
ক্যামেরা ফিল্ম শেষ।
একসঙ্গে তুলে দিয়েছি।
1 ঘন্টা বকবক করতে দিয়েছি, নামিয়ে নেয়।
না, তবে ভালো হয়েছে।
ডিসকাশনটা ভালো হয়েছে না?
কেস
কেস
বেস হয়েছে বলে ভালো হয়েছে।
একসঙ্গে
নাহলে
দিয়ে
কেউ
দিচ্ছি।
শুনতো না।
কেসগুলো খুব সুন্দর আপনি ফর্ম করেছিলেন। সবাই ওকেই করে দিয়েছে।
Presenting it to Dr. Bhaskar Ghosh and finally to Dr. Vasudev Bhattacharya.
আচ্ছা সবাই দাঁড়িয়ে পড়ে ওটা হাতে নিয়ে
দাঁড়িয়ে পড়ো, সবাই একসাথে। দাঁড়িয়ে পড়ো। না না না, ঠিক আছে। We request all our guests to join us for the cultural program, which will start from 6:30 p.m. sharp. 6:30 p.m. sharp, and then dinner to be followed from 9 p.m. onwards. We request all our guests to attend this cultural program this evening. Thank you.